Good morning. I call this hearing to order. A quorum is present. Pursuant to Committee Rule 4 and House Rule 11, Clause 2, the Chair may postpone further proceedings today, and without objection, the Chair is authorized to declare a recess at any time. Thank you, Secretary Wilkie, and your team for coming in to discuss the Department's Veterans Affairs budget request for fiscal year 2021. I also want to welcome our VSO partners and look forward to hearing their views on our second panel. And despite a requested 12% increase for VA's budget, I'm deeply concerned this request ignores a much worse reality. This budget could lead to less food on the plates of struggling veteran families, no new housing vouchers for homeless veterans, and millions of veterans cut off from key support programs. This 12% increase comes at the expense of significant cuts to critical domestic programs that veterans, especially those in crisis, depend on. 1.7 million veterans rely on Medicaid, but the President's budget would cut Medicaid by $900 billion over the next 10 years. More than half of all veterans, approximately 9.3 million, rely on Medicare, but the President's budget would cut Medicare by $500 billion over the next 10 years. Over 600,000 disabled veterans receive Social Security disability insurance a year, but the President's budget would cut Social Security benefits by at least $24 billion. And nearly 1.3 million veterans live in households that participate in SNAP, but the President's budget would cut SNAP by $182 billion over the next 10 years. And as of January 2019, there are 37,085 homeless veterans, and HUD's rental assistance program would be cut by $3.5 billion. Additionally, the President proposed we slash almost $700 million from the Center for Disease Control 2021 budget, the very agency on the front lines of the coronavirus response. Meanwhile, the CDC warned this week that there will likely be an outbreak of the coronavirus in the United States. The President requested a separate supplemental in response, but it is wholly inadequate and would actually raid the funds set aside for other life-threatening public health emergencies such as Ebola. As the nation responds to the coronavirus outbreak, we cannot forget our veterans. They will not be immune to this virus, and under VA's fourth mission, it is our responsibility to ensure VA is prepared. And while I'm pleased that this budget places significant investments in mental health care for veterans, a top priority for this committee, VA and the President, it's a top priority for this committee, VA and the President, I'm alarmed that resources are directed outside the VA into grant programs and the Prevents Task Force instead of being used to explicitly support veterans in crisis. As demand for VA mental health services continues to grow, we need to ensure VA programs are fully funded before this money is directed elsewhere. I also emphasized in my remarks yesterday during the VSO hearing that I have made reducing veteran suicide my #1 priority, and that's why the committee adopted a comprehensive, evidence-based framework to address the crisis of veteran suicide from every angle. Our approach takes into account multiple factors that could reduce veteran suicide, everything from lowering economic burdens to increasing access to care and improving crisis intervention for those at higher risk. While funding is increased to reduce veteran homelessness, a factor that may lead to suicide, HUD faces significant cuts itself, and for the fourth straight year, HUD has zeroed out any new HUD VASH vouchers. And I can tell you from experience representing my constituents in Riverside County that these vouchers are essential to ending homelessness. This program is a partnership between VA and HUD provides the housing assistance, and VA provides the key wraparound services. It does no good to only fund the VA services side of the partnership. Veterans need housing provided by these HUD vouchers. And for this, while we need these both to work, for HUD-VASH, the program, to reduce veteran homelessness. Both VA and HUD need to be fully funded. VA also increased its budget for gender-specific women veterans health care by 9%, but its funding for hiring and training the clinicians and staff who run the women's health program is far below what is needed according to the independent budget. The chronic under-resourcing of women's health at VA is an indication of the greater cultural issue of fully valuing women veterans. And if we want to have an honest conversation about suicide prevention, we need to address the culture of sexual violence against women at VA. Currently, VA does not even require mandatory bystander intervention training for all employees, contractors, vendors, and volunteers. When Congress passed the Mission Act in June of 2018, tens of thousands of pre-9/11 veterans and their caregivers won a hard-fought battle for equality in their 9/11 counterparts, with their post-9/11 counterparts, a battle that took nearly a decade. However, VA's inability to meet congressionally mandated timelines has prevented these veterans and their families from accessing these services. The budget requests $1.19 billion for 2021, which is a $485 million increase over last year's funding levels for the program. However, to date, VA has not released the regulations outlining changes to the caregiver program that were authorized by the Mission Act. Without finalized regulations published, it is unclear how accurate VA's budget request for this program is, potentially further breaking an already broken promise. The budget also requests additional employees to help with Blue Water Navy claims processing, but ignores funding for claims and treatment for other herbicide-exposed veterans, despite extensive and credible evidence that their conditions are related to Agent Orange exposure. I sent a letter to President Trump with 77 of my House colleagues to ensure 4 diseases were added to the presumptions list. Senate Democrats and VSO leaders have called for the same inclusion, but there has been no response from this administration. I was disappointed to see that the Secretary did not even address this injustice in his prepared remarks. That and the fact that this budget does not request any funding for these additional diseases signals that this administration is not making progress on this matter. These veterans have already waited too long. Despite all of these increases, the President's budget would hurt veterans by slashing programs that ensure essential needs are met. When you consider it in its entirety, this budget is a cruel document that cuts housing, food security, health care, and key assistance that millions of veterans depend on. Now, instead, I suggest that we have to work together to ensure that we can keep the promises that we've made to our veterans and ensure that our budget reflects humane values. So, that concludes my opening remarks, and with that, I recognize Dr. Rowe for 5 minutes for his opening statement.
Thank you, Mr. Chairman. I think it's fair to say that you and I view this budget through a very different set of lenses. When I came to Congress 11 years ago, the Department of Veterans Affairs budget was $97.7 billion, which supported just over 260,000 employees, and that's medical benefits and cemeteries and health care, as it does today. Today, we're examining a VA budget request that totals $243.3 billion, almost $250 billion, that would fund more than 400,000 VA employees, much larger than the U.S. Navy. That's an increase of $145 billion, almost 150%, and 140,000 full-time employees, approximately 65%. Since 2017 alone, VA's budget has grown by $60 billion, and VA staff has grown by more than 50,000. And that, as you can see in the graphs behind me here. Increased government spending certainly does not always equate to improved government services, sometimes quite the opposite. However, this tremendous investment in our nation's veterans has more than paid off under this president. Not only is VA more well-funded, well-staffed than ever before, but it is unquestionable that veterans are better served. I hear it every day when I go home now. Compared to President Trump's first day in office, veterans today have more access to care, more choices in care, more control over their care than any other time in history. Veteran unemployment has reached near record lows. Veterans are expressing significantly greater trust in the VA. Veterans are able to use their GI Bill benefits whenever they choose. Veterans are getting their appeals for disability compensation decided faster and more efficiently. I remember we were in the Cannon Building in my first term. General Shinseki said, we have 1 million backlog disability claims. We have 100,000 homeless veterans, and I applauded him for trying to get this number down. And Dr. Lawrence, and hopefully in his remarks, will tell us where that is. It's rather remarkable what's happened for disability claims. Veterans are getting more support during their transition out of the military. Veterans are able to go to urgent care clinics in their neighborhoods instead of traveling to VA hospitals for things like just a cold or a sprained ankle or whatever, something minor. Veterans who served in the Blue Water Navy during the Vietnam War are finally receiving the benefits they've earned. And let me tell you, that was a bipartisan on both sides of the aisle that got that done. It was not easy. It was fully paid for. It's done. We should take a victory lap for that. Fewer veterans are homeless. 100,000 when I came here, which was unconscionable, now down to the numbers somewhere in the 30,000s. And by the way, there are 10,000 unused HUD VASH vouchers, 10,000 right now that have not been used that should be. Fewer veterans are dependent on opioids, which is great. The widow tax that financially penalized surviving spouses of disabled veterans has been repealed. Caregivers of seriously injured pre-9/11, that's my generation, veterans, will soon receive the same support that caregivers of post-9/11 veterans received. VA has begun the process of modernizing its electronic health record and achieving true interoperability with the Department of Defense. VA has become one of the 6 best places to work in the federal government, from number 17, the worst. Poor performing employees are being held accountable. Whistleblowers have additional avenues to report concerns and be protected from retaliation. I could go on and on and on. Just look at the charts behind me, which are available on the minority website. And that's certainly not to say our work is over. It's far from it. It will never be completely done. But it is to say that the staunchest critics of this president are being disingenuous when they claim that he has not put veterans first and that his policies have not led to clear improvements in the lives of veterans and their families, as I believe the previous administration did. As for the work still ahead of us, many of the accomplishments I've mentioned earlier, which are listed in the graphs behind me, will require the ongoing leadership and oversight of this committee and our partners in VA and in the veteran service organizations. I remain particularly concerned about the state of VA medical facilities across the country, which is why I fought so hard to include the Asset and Infrastructure Review as part of the Mission Act 2 years ago. AIR is the most transformational yet least discussed aspect of the Mission Act. It has the potential to permanently change the way VA delivers care across the country and help veterans, particularly those in rural, remote, and minority communities who aren't being well served by the crumbling infrastructure that exists throughout the VA healthcare system. Just yesterday, I had a state veteran service officer in my office, along with their organization from Montana. Very, very rural area. There's a new, he says, the newest facility in the state is a hospital that has half their beds are full. And many veterans have to travel miles and miles. We can look at that new hospital and partner with them to help the local community and help veterans. That state veteran service officer told me that they opened an office in their community right there where they worked so veterans wouldn't have to drive 65 miles for mental health services one way and 65 miles back, and many times in a snowstorm. It's used 5 days a week. Those are the things we need to be doing for our veterans, and we are. Veterans in the 21st century deserve to have access to the high-quality care close to their homes in facilities that were designed and built to provide modern medicine, not the ones who are relics of years long gone and that exist in neighborhoods where veterans no longer live. Change is not easy, I got that, especially for a healthcare system as antiquated and entrenched as VA. But AIR presents an incredible opportunity to preserve the VA for future generations of veterans. We cannot let this pass us by. But perhaps no greater challenge remains than preventing veteran suicide, and I completely agree with the chair on what his primary object is to help lower that. I could not agree more. If the number of veterans who died by their own hands every year in combat, that were died in combat instead, there would be a worldwide outcry and calls for action, as we're doing now with the coronavirus. We should be doing that with the 6,000 veterans in active duty who commit suicide each year. Those men and women are dying on a different battlefield instead of, and far too long, their deaths have been accepted as inevitable. They're not. Incredible efforts have been invested in ending this crisis. But those efforts have failed, and they will continue to fail until we are collectively brave enough to challenge the status quo, connect with the majority of veterans who are outside the VA's reach, and provide them with the support and care that they need where they are, without requiring them to come to us first just because that's how we've always done it. I know that this president and this secretary agree with me on that point, and I appreciate their leadership and their commitment to doing so. And clearly, great progress has been made. You could be forgiven for not being aware of just how much, because when it comes to veterans, we seldom talk about their triumphs as loudly as we talk about their trials. That does a real injustice to them and is a narrative that I would like to overturn in my final year on this committee. But for now, I will simply say that whenever we, as a grateful nation, have invested in the brave men and women who fought in the defense of our freedoms, it has paid dividends not just for them, but also for our country and our future. This budget is a wise investment in our future, and I wholeheartedly support it. I thank all of our witnesses for being here, and Mr. Chairman, I yield back.
Thank you, Ranking Member Dr. Rowe. And appearing for us today is the Honorable Robert Wilkie, Secretary of the United States Department of Veterans Affairs. We have Dr. Richard Stone, Executive in Charge of the Veterans Health Administration, Dr. Paul Lawrence, Undersecretary for Benefits, Mr. John Rachalski, Assistant Secretary of Management and Chief Financial Officer. And we look forward to hearing your testimony today, Secretary Wilkie. I now recognize you to present your statement.
Thank you, Mr. Chairman, and thank you, Dr. Rowe. I appreciate, again, this is my second time as Secretary. I made an appearance talking about programs as the acting, sitting under the picture of an old friend of mine from many years ago, Walter Jones, the late Walter Jones Sr., so it is good to be back. I want to pick up on something that Dr. Rowe said that I'm in wholehearted agreement with. The Department of Veterans Affairs looks nothing like it did a few years ago. A few years ago, there were incredible stories of failures and excuses. And today, we are not only leading the country in innovation and modernized systems, but above all, we have satisfied veterans. VA has implemented the most far-reaching transformational programs since the GI Bill was signed by President Roosevelt in June of 1944. We have put in place, just in the last year and a half, the Colmery Act, the Mission Act, the Blue Water Navy Act. That is a record of achievement that I think most federal departments would be proud of. And what makes me most proud is our ability to make these sorts of changes without missing a beat when it comes to serving America's veterans. In the last few years, I've heard a great deal of debate about the Mission Act being a gateway to privatization. Well, last year, we completed almost 60 million internal appointments in the Department of Veterans Affairs. That is an increase in 1.7 million internal appointments, even as we sent 2.8 million to outside care under mission. 90% of our veterans across the country, according to the surveys, trust the care they get at VA. Surveys continue to show that we're competitive with the private sector on wait times and quality. And much of this improvement has happened because we've brought back accountability to VA and released more than 8,000 staff who were not performing. As Dr. Rose said, 2 years ago, we were sitting at 17 out of 17 in terms of best places to work. Today, we are at 6. One of the reasons for that, other than accountability, is what we call the high reliability organization. I have made it clear that VA is a bottom-up organization where people at every end of the strata have a say in how their work is performed. They have a say in how their leaders perform their work. And I think that has gone a long way to improving morale amongst our staff. And if morale amongst our staff is high, the care for veterans is much better. In addition, our staff continues to innovate and improve the quality of veterans' lives. It was the Department of Veterans Affairs that brought America the first cardiac pacemaker and the first liver transplant. Now we're leading the way on cancer treatment. Precision oncology promises new ways to attack cancer by not attacking the patient. And in Northern California, at Palo Alto, we just put online one of the first 5G hospitals in the United States that will allow us to deliver telesurgery services remotely to veterans across the country. And it is telehealth, as Dr. Rowe pointed out, that will allow us to reach those veterans, particularly those veterans in the western United States and in the Pacific Islands, where we can diagnose patients remotely without forcing them to encounter long journeys. Now, we have several challenges on the horizon, as the chairman pointed out. Next week, I expect the caregiver regulations to be published in the Federal Register, fulfilling a promise that I made to Senator Murray that the program itself would not change until we actually had regulations in place and an IT system that is ready to go for all veterans. I take this personally. Some of you have heard me talk about my experiences growing up as the son of a combat soldier from Vietnam. My mother was a caregiver. My father passed away about 1.5 years ago, and when I last saw my mother at the end of last year, she did tell me about the suffering that he engaged in, which we think was from chemical poisoning, which is why I place particular emphasis, as the chairman does, on getting the presumptions for Agent Orange right. I've seen it happen in my family. So that is a promise to you that I am doing everything as diligently as I can to make sure that we don't go through what those veterans went through so many years ago, and that we set the pace for the future for those veterans who have come since Vietnam. We are closer on the electronic health records. I did inform the committee that I delayed the rollout by a few weeks because we weren't ready to train on a system that was not 100% ready for those who would be using it. I think this is also an example of the change in morale at VA. I gave the practitioners on the ground in Eastern Washington the power to tell me, Mr. Secretary, it's not ready to go. And I was not going to have thousands and thousands of practitioners practice on a system that was not ready. I am very gratified at the progress that we have made. I think we are in a much better place than many of the private sector hospitals were who engaged in this development many years ago, the Mayo Clinic, Children's Hospital. I think we are in a very good place to finally deliver that long-gone promise so that when a young man and woman comes into a military entrance processing station, they have an electronic record that is built for the rest of their lives, so people like my father never carry around an 800-page record for the decades that they lived after they left military service. And as the chairman noted, in a few weeks we will present the Prevents Task Force report for a nationwide plan to work with state, local, and tribal groups to identify veterans who are at risk of suicide. And in addition to what the chairman said that I take very seriously, we are offering more services to women than ever. Women like what they see. More and more are enrolling at VA. As of last year, 41% of all American women veterans are enrolled at VA. That is compared with 48% of all male veterans. Last year, 84% of all women veterans surveyed said they trusted the care that they received at VA. And we have a zero-tolerance policy for all of that behavior that makes women uncomfortable. I will leave you with one more initiative that we are pursuing that is important to me. I have been accused of being an amateur historian, and I plead guilty. The most spiritual speech ever given by an American president was the second inaugural address of Abraham Lincoln that would have been presented 150 years ago next week, where he laid out his vision for what was then known as the Veterans Bureau. I have asked that that address be placed in all of our cemeteries to remind us of that sacred bond that the country has with those who have shared, as some on this dais have shared, the incommunicable experience of war. And I can think of no better way to set in place what we should be about than having Mr. Lincoln's words available to all of those who are coming to visit those veterans in their final resting place. And Mr. Chairman, I thank you for your courtesy.
Thank you, Mr. Secretary, for your testimony. I now recognize myself for 5 minutes for questions. And I'll begin, Mr. Secretary, with this topic of electronic health record modernization. Very simply, is the new timeline for the electronic health record modernization go live July 2020?
Well, that certainly is a goal that I would like to achieve. You and I discussed on the phone the reasons that I delayed the training on the system. 2 weeks ago was always the date that I had chosen to make sure we would be ready. I'm confident that we will be. I'm also confident that Seattle will be online later in the year. Dr. Stone is actually more on the ground on that than I am, and I think he can fill in the blank on some of the issues that I've missed.
Just before Dr. Stone, are you saying it will or will not be July 2020?
Well, that is my goal.
It's your goal?
Yes.
Right.
Yes.
So are you reasonably, do you think it's possible?
I am confident that we can fulfill our mandate.
But the go live will be July 2020? We're on
Well, I
track
would
for
hope
that?
I would hope that it would be earlier, but I am focused on making
July-
sure. Yeah, we're on a glide path to get there.
So July 2020, if not earlier, we're on a glide path. I mean, look, we've always said on this committee that, and I think, Ms. Lee has also said, we'd rather get it right. But we also just want you all to be transparent with us and just tell us, what you need. So,
I would also say, as a way of complimenting, this committee has done things that I have not experienced in my other positions in the Department of Defense with other committees. You have graciously recognized the complexity of this program. It is the most complex program the federal government is undertaking, and you have given me gracious opportunities and great leeway to fulfill your mandate.
well, look, I think, I hear what you're saying, that you want to go, that we're on track to go live by July 2020. It could happen earlier. I certainly hope that you'll tell us if there will be more significant
yes, sir.
delays beyond that, okay?
Yes, sir.
I do want to get into some other questions, though. Is the rationale for the delayed development?
The rationale was that when I reviewed it, the two portions of the program that were not ready for our clinicians were programs that are incredibly important, particularly to the West, travel and community care. Those programs weren't ready. We have a great relationship with our private sector partner. We have a great relationship with the Department of Defense, but I was not satisfied, and I had promised you and Dr. Rowe that if I was not satisfied, we would not launch. We are working on those interfaces right now. One of the highlights of our effort is that, and I should invite you to come see it. We've created the equivalent of what we in the Air Force call an Air Operations Center that's working around the clock
Well, we were
work
told,
this problem.
we were told that before, we were told before it was change management and workflow and then a capabilities issue.
Mr. Chairman, if I may, it is development. There is about 1,000 work processes that need to be written. Those are substantially completed. But once you finish those work processes, you've got to set that electronic medical record into a number of interfaces that plug into the rest of the system. There are 73 interfaces. 19 are completed as of today, and that is why we are delayed. This is development.
Thank you, Dr. Stone. I want to move on to COVID-19 preparedness, coronavirus, and a supplemental funding request that's now before the Congress. Does VA need supplemental appropriations to prepare for a major coronavirus outbreak, including procurement of additional protective equipment, training for VA employees, and deployment of VA employees as part of disaster emergency medical personnel system teams?
Not at this point, Mr. Chairman, and as you know from earthquakes that have hit California, we're a foundational response for the United States healthcare system when it comes to emergencies like this. We train for them year-round because when hurricanes hit, when earthquakes hit, we are the responding force. We are testing our processes as we speak. We are making sure our supply chain is full. Right now, I don't see a need for us.
What about staffing and funding for the Office of Emergency Management?
We are set. Right now, we are set.
Dr. Stone, you agree with that?
I do. Now, if this develops into a pandemic in which portions of the American healthcare system break down, we're going to have a different discussion. But at this time, as we take a look at the planning and what was outlined yesterday in the presser that was sent out, as well as briefed yesterday from the White House, we see ourselves as well prepared.
And let me get you a brief on our emergency preparedness.
I just want to make sure that we have this opportunity in this supplemental I just want to make sure you all have thought this through and what you might need. I mean, we saw what happened when just one person in Houston that they thought might have it, but I don't think that he did have it. But the reaction throughout through that area. Listen, I'm gone over time. I want to recognize Dr. Rowe for his 5 minutes.
Thank you, and just to, Mr. Chairman, to dovetail on what you're talking about, you're absolutely right. I've noticed this for years in practice in medicine. What scared patients is the unknown. And so what you have to do, we have to get accurate information to people about this particular virus and what it does and what it can do. And I think if it's a 24-hour news cycle, you can get people completely worked up about this. We have the resources in this country as opposed to many countries. And Dr. Stone may want to share his experience with someone in France to show you how different it will be here about how we handle these. We are the best in the world at this, and we will get through this just fine. I feel very confident that we can. And I also feel, Mr. Chairman, that we in the Congress, whatever the number is, we're arguing about a number, will provide the resources to take care of the American people. I have no doubt about that. There's not going to be an argument. When we figure out what that is, and we have to rely on the people who do this, we will provide those resources. I want to ask a couple of questions. One, Dr. Lawrence, I want to start with you because the thing that we hear in our offices or back home more is why is it taking so long to get my disability claim adjudicated? Would you please just give us a rundown on where that is right now after Mr. Boss passed? I guess now, Mike's been 3 years ago that bill passed.
Sure. As you recall and you alluded to, in 2013, the backlog of claims peaked at 611,000. Those were claims over 125 days, and they were taking 6 or more months to process. Right now, the backlog this morning is a little north of 72,000. In November, it hit an all-time low of 64,000. We processed claims last quarter, period of October 1st through December 31st, at an average of 91 days. There are some that are more complicated that take longer. No two claims are exactly the same, but this is a significant reduction compared to the same quarter at the beginning of FY19. We processed 12% more claims with the same people. We are providing faster service for veterans and more consistent results. So we're doing more with the resources you've provided us.
Well, thank you for that, and I know that I've heard constituent after constituent talk about, and especially with the rapid appeals modernization went along, about claims that had been out for years. It got adjudicated in 2 or 3 or 4 months, and these veterans are very appreciative. Another thing very quickly I want to go to, I think is one of the most, a very important component of the Mission Act, which is the AIR Act. And I'd like to know exactly the status of the market assessments right now, and that'll form the basis of the recommendations to the AIR Commission.
Yes, sir. We have conducted market assessments in 6 or 7 VISNs. That's a component of the 96 market assessments that we're doing that look at our services, our footprint, our partnerships, everything from building new facilities to leasing other facilities. I have a report date of January 2022 to the Congress. I will continue to ensure that we do this as rapidly as possible so I can actually get ahead of that report date. I think it's absolutely vital. We've never really had a complete inventory of what VA has and where VA is. And I do think that this is a key component for our future. Without it, we will again be moving into the future blind, and I'm very supportive of that position, that part of the Mission Act.
I hope that the Congress has the courage to carry out because it's critical for the future. We can't keep just throwing money at a problem. There's a more efficient way to do it, and it's just the way health care is provided today. Now, this was in yesterday's Washington Times, which I thought was very concerning. Temporary doctors feel increasing shortages at healthcare facilities. So we have a very good synopsis of what I've been saying now for years. We have a shortage, and in the next 10 years, we're going to have to learn to do things more efficiently and better, both in the private sector and in the VA sector. And I think this is one of the reasons that the AIR Act is so important to use, and the Mission Act, to use the best assets of both the private sector and the VA sector. I think as a shared responsibility, we can take the best care of our veterans in that way. My time has expired, and I yield back.
Thank you, Dr. Rowe. Ms. Brownlee, you are recognized for 5 minutes.
Thank you, Mr. Chairman, and good morning, Mr. Secretary. I'm going to try really hard to get 3 questions in, so we'll see how I do. First question is around women veterans. I think you recently referenced that there are 780,000 women veterans in the VA. However, the budget represents or references 545,000 roughly unique women veterans. So can you confirm that the distinction is between enrolled women and actual veteran patients?
Right. There is a difference between enrollees and patients, and that's the same for men as well.
Okay, so in some other testimony, the VA said that in fiscal year 2019, the number of unique women veterans grew to 821,000. So it just seems to me that the population, I'm a little confused, but that population is not totally represented in the budget.
Congresswoman, there are 780,000 enrolled women veterans, 510,000 active users, growing to 548,000 active users in the 2021 budget. So about 8% growth, about 9% increase in the budget.
Okay, and what we also know that women veterans represent the fastest growing subpopulation of veterans, and we are continuing to try to keep pace with that. And since fiscal year 2000, women veterans have more than tripled and are currently 30% of net new users of VA healthcare are female, yet the budget is only reflecting only about a 9% increase in fiscal year 20. Do you think there is adequate sums of money here to meet the need?
Yes, that is for gender-specific care. We have a much larger budget for medical treatment that both men and women would need because the conditions cut across gender lines.
Well, again, my data tells me that there's about 76% of women veterans now are assigned to a trained women's health primary care provider, which is, still under where we aspire to.
Well, right now, we have at least 2 dedicated women's health care providers in all of our VA facilities. We have hired just, I think in the last year, 7,000 providers and nurses, or we've trained them just on women's-specific issues. So it is something that is absolutely vital if we're going to provide those services.
Thank you, sir. And now I want to go to the caregiver program, and I think you mentioned that the regulations will be published next week. I'm going to take your word for that. The buck stops with you, Mr. Secretary. And so assuming we'll be reviewing those next week, where are we with regards to the new IT system for processing caregiver program applications?
The program is progressing well. The IT system has come online, and we've moved most of the existing 20,000 families that are on this onto the system. The second phase that will be exercised next month is the ability to pay claims or to pay the benefit on an automated basis instead of handwriting that number of checks each month. And then the third piece will be the automated intake of new applicants. And so we are quite optimistic that by this summer, the program will be ready for the Secretary to certify for expansion.
So you're saying summer of 2020, you will be able to accept applications electronically?
That is exactly where we'd like to be. But please remember, this is a very complex regulation of more than 200 pages of regulation. And we do anticipate a robust response to the proposed regulation.
So can I just get your commitment then, if we fall off of that mark, that you'll let us know so that we can stay abreast of that? I'd appreciate it. Last question is the issue around sexual harassment within VA facilities. And just in reviewing the budget, I know, Mr. Secretary, you've initiated a program, Stand Up to Stop Harassment. And just looking at the budget, I can't really identify resources dedicated to that program, and I'm just curious if you could further articulate a little bit more with regards to funding, including advertising materials and videos, so that we are really getting this information out at every corner of VA facilities.
We've instituted a program called Stand Up to Stop Harassment. We've instituted about $500,000, or we've put $500,000 into the budget to generate products that will train not only our employees, but also our volunteers and those coming through. You will also see in our lobbies pictures up about demonstrating respect for fellow veterans. And so all of those are present within the budget.
And I would add to that, we are engaging in a new bystander training program. It's one thing to put up a poster, but we need those people who are in that facility to be trained. About 7-8 months ago, I put in place a similar program that I put in place at the Department of Defense, and that is a task force that looks at culture. It looks at the way we report these things. Dr. Stone has brought into his immediate office a senior level official who focuses on nothing but that. So that is part of this great cultural change that the active duty and the veterans component has to go through.
Well, I thank you for that, and obviously, we're looking for persistence in this endeavor, and I'm way over my time, and I yield back.
Thank you, Ms. Brownlee. Mr. Bilirakis, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate it. And Mr. Secretary, thank you for your service, and you truly are making a difference. I see it locally in the Tampa Bay area, but all nationwide.
Thank you,
And I appreciate your service. First question is, there have been some, Mr. Secretary, there have been some who have said the President's budget request is cutting services to homeless veterans by not requesting additional HUD-VASH vouchers. Is it true that there are over 10,000 HUD-VASH vouchers, or 10% of all the HUD-VASH vouchers that Congress funded last year that are not being used?
That is true. Most of them are unused because they are in very high-cost areas that we haven't been able to meet the rents. I've been in contact with, and I think I've mentioned this to the chairman, leadership, particularly in Los Angeles. We are working with them to find some way to get around this problem, more transitional homes for veterans homelessness. We're expanding the facilities that we have, particularly in Southern California. But yes, that is true. We have 10,000 that have not been used.
Yeah, and we did have a hearing in Southern California with Congressman Levin, and that's what we heard as well. And I think even in my area, the cost of living is very high, so I would appreciate you working on that. Thank you for doing that. But it is unfair, would you agree, that the administration is being criticized for not requesting new vouchers when there's more than 10,000 vouchers available?
Sir, I understand your point. As part of this budget, we've added $30 million for additional caseworkers to work those. It is specifically, our problem is in very high-cost communities where we just can't get the participation of enough private owners to participate in this. But we are adding additional resources just because of the complexity of having to work each case.
And I would add the success story. And Dr. Rowe mentioned the decrease from hundreds of thousands to the 38,000. Just in the last 2 fiscal years, we have managed to find homes for 125,000 veterans and their families. The way this will continue to work, though, is that we have to enhance our partnerships with the private sector, with charities, with non-governmental organizations, so they can help us go where we don't go to find those veterans who are on the street.
And getting the additional case managers will help you do that, correct?
Yes, sir.
So it's a smart move. I mean, this is a priority of the administration. Obviously, it's a priority of this committee as well. Okay, Mr. Secretary, I've seen in the American Legion's testimony, which we'll hear on the second panel, that VA should consider public-private partnerships with community hospitals to increase VA's market penetration in underserved areas by renting space in existing facilities. Now, we don't need that in my area, but in other parts of the country, I think it's necessary. I also strongly believe that we can leverage the already existing framework of community health centers to increase VA's footprint. Would you support these concepts? And just give me your opinion on that, because I think it's important, particularly with the community health centers, and that's all over the country. They do such a wonderful job.
Well,
And it will make veterans' life a lot easier to travel there as opposed to going to a hospital, which may be hundreds of miles away. Yes, please.
that's the beauty of mission. In fact, I never remember the entire acronym, but the words, the letters that I do remember are integrated network. Mission allows the veterans the choice to find those community providers. There are about 880,000 community providers across the country. That could be community hospitals or doctors or nurse practitioners. So our goal is to get veterans to the care that is most advantageous to them.
Thank you very much. And Doctor, do you want to add something?
No, not in addition to what the Secretary said.
Okay, thank you very much. And again, thank you for your service. And I'm telling you, I mean, I hear from veterans everywhere that you are truly making a difference. God bless you. Thank you, and yield back, Madam Chair. Mr. Chair.
Yeah, thank you, Mr. Bilirakis. Mr. Lamb, you're recognized for 5 minutes.
Thank you, Mr. Chairman, Mr. Secretary, everybody. Thank you for joining us today. Mr. Secretary, thank you for everything you're doing, but especially for starting off today by mentioning your father and his service in Vietnam and what he went through. Because, you know, I really just want to focus for a second on the men and women who are out there right now with hypothyroidism, hypertension, Parkinson's symptoms, and bladder cancer. Those 4 conditions that have still not been added to the presumptive list. And I'll just state up front that this is an injustice. It's an insult to these men and women. I believe that the responsibility lies at OMB. I don't believe it lies with the 4 of you. From what I can see is publicly available, the Secretary wanted to add it back in 2017. Then Secretary Shulkin, OMB turned him down pretty clearly. The reasons are not clear, but they have turned him down. I just want to confirm your understanding of a few facts, though. Do I have it right that if you take these 4 conditions as a whole, there are probably around 190,000 veterans who would receive benefits under those 4 conditions, and then that number would grow over time?
I think it would. As to the growth, I would have to look at the actuary tables because the population is beginning to leave us.
So 190,000 veterans who, as you say, are beginning to leave us, suffering from these incredibly serious conditions. I mean, just Parkinson's alone, the drugs can cost thousands and thousands of dollars for people every single year. The estimate I've seen publicly reported is that adding these 4 conditions would cost about $11 to $15 billion over time. Does that sound familiar? 11 to 15 billion over 5 years?
Correct.
That's correct, okay. And that is what OMB has rejected due to the cost, is that correct?
I can't tell you what their reasoning is today.
But it's a fact that OMB has rejected it. So the thing is that, I mean, I think that their case has been couched in terms of protecting the taxpayers, making sure we can actually pay for the things we promise veterans, which all sounds nice in the abstract, but the exact same OMB is promoting and requesting a budget that asks for $22 billion of an increase this year alone for VA as a whole. It's not as if they're pinching pennies throughout the VA. It's not as if they're pinching pennies throughout the government. We now have over $1 trillion of budget deficit. So this is about choices. If these 4 conditions going on the presumptive list would mean $11 to $15 billion over 5 years, that is in fact less than VA's overall budget request increase this year alone, correct?
That is
Just
that
the
is-
math.
Yeah,
It's a
the
mathematical
math
question.
is correct. The distribution probably wouldn't work dollar for dollar given other needs that we would have.
Yeah, and no one's saying that there are not other needs, but this is about making choices. And you know, when we passed the expansion of community care, the Mission Act, one of the things that we called attention to was the conflict between mandatory and discretionary spending that would create. And we were very concerned about it. As you noted, people were concerned about privatization of the VA. I will commend you for how you've executed Mission Act so far. This year went smoothly in my district from what I could see, and the administration has continued to request more money to fund Mission Act so that didn't happen. But again, it was about choices. The administration's response at that time was basically, don't worry. We're going to make sure veterans get the money that they deserve. We're going to take care of these people if we send them out to the community. We're going to pay. We're going to find a way. That is now not happening with the people who are suffering from these 4 conditions. And as you said, they are starting to leave us. The clock is ticking for them. The clock isn't ticking as much for a 35-year-old who might want to get medical care in the community. But that's who OMB and the administration is choosing, and that's what's wrong. And I know you're working hard for these veterans, and you're making the case, I can tell. So please don't give up and try to convince these people over there that this isn't about saving money. Our government sprayed them with Agent Orange. We are the ones that did it to them.
So, Congressman, none of the decisions that we've recommended to the Secretary or have been recommended to OMB have been based on how much this costs. It has
Thank
to
you.
do with the science. And the science, unfortunately, is difficult. The National Academy of Science went over these 4 conditions. And
It is.
unfortunately,
My
they
time's
took-
about, it's impolite to cut you off. My time's about to expire, but I just want to reiterate that the level of evidence related to these 4 conditions is similar to the conditions that are already on the presumptive list. They're not novel or unique in that respect. So science can differ, but you also have to add into it that it's similar to how we've done it in the past, and again, the clock is ticking. So at a certain extent, it becomes who bears the burden, the government or the veteran? And I believe it should be the government, Mr. Chairman.
And I know you're over your time, sir, but I'll give you my commitment because it is personal. That the Vietnam soldier is of particular meaning to me. That was the world I was born into, and I take your passion seriously.
Thank you, Mr. Lamb, and Mr. Secretary. I appreciate your responses to Mr. Lamb on this issue. I agree with him that I think I don't see you gentlemen responsible for these 4 conditions not being listed on the presumptive list, and this is something that I hope that we can resolve quickly. I now recognize Mr. Bost for 5 minutes.
Thank you, Mr. Chairman, and I want to thank you all for being here as well and what all you're doing. Dr. Lawrence, as you know, the VA recently faced challenges responding to legislative requirements like those under the Forever GI Bill that Congress passed to enhance education benefits for our veterans, service members, families, and survivors. How would you assess the VBA's state of preparedness today, particularly from an informational technology perspective, and if you were required to carry out implementation of additional legislative provisions, what challenges would you still face?
As you know, part of what got us through the journey through the GI Bill in calendar year 2019 was the old technology and the inability to respond agile to the new requirements passed in the Forever GI Bill. The assessment coming out of that, which was completed successfully on December 1st, and we're in the process of truing up per the Secretary's guidance, is that the technology is very, very old, making it very difficult for us to provide veterans world-class service that they're used to in the private sector, as well as limiting the possibilities that additional changes to the GI Bill will be done cheaply, if at all. So there is a real sense that time is near to not just continue to upgrade this old technology, but to really rethink the acquisition of new commercial off-the-shelf software and implement it in such a way that going forward we will not face the same problems.
So if you were provided with additional funding for IT, what would your priorities be?
Sure. We've done a preliminary assessment, but I'll give you a broad assessment. We would purchase 3 commercial off-the-shelf packages, one called Customer Relationship Management, so when veterans call up, we know everything about them when we're on the phone. This happens when you interact with a bank or insurance company now. We'll purchase high-tech computing power to do calculations. This happens when you take a dependent off your insurance company and they tell you the reduction or the addition. And we'll have sufficient data capacity so we can have all the information from the schools and the veterans so that it's all right there. These are commercial off-the-shelf acquisitions, companies that exist that do this all the time now. With additional funding, that's what we would do. The implementation of this should take between 18 and 24 months. We have MITRE presently studying this exactly as to how it would be done so that we could do this when the resources are available.
Okay, that's what I wanted to get on the record, so we knew, the efficiencies we can move forward with the proper investments. So, excuse me, my next question is for Dr. Stone. You've spoken to some about S3084. It's a bill that passed out of the Senate in January that would correct a technical error in the law that impacts leaders working in senior executive positions throughout the VA and within the VA healthcare system. It is actively making it harder for VA to recruit and retain necessary talent to serve veterans. I've been working to get the bill passed out of the House as soon as possible. Could you please briefly summarize what the advantage of having this passed would do for you?
Congressman, 10 years ago there was an error made in 2 sections of the law that allowed us to pay SAS equivalents, a market rate. We discovered this as part of the last pay raise. It placed us in a very difficult position that in essence states in one section of the law we may have overpaid those senior leaders. I have 30 active senior leaders These are the people that head my pharmacy program, head our suicide prevention program. These are the key working leaders of this organization. So the problem we've got as this sits is that I can't do anything with those employees. We will trigger additional potential debt for them unless we lower their salaries. In addition, we can't promote any of them. We can't move them someplace else. I can't hire. They can't retire. This is an extraordinary morale killer for 30 of our key leaders, and we would hope that your efforts would result in continued movement.
And I would add to that, and the chairman and Dr. Rowe have worked on this in the past. We have a larger issue, and that is remaining competitive when it comes to paying doctors and nurses, particularly in high-end specialties. It's my desire to break out of the compartments that have existed in terms of the federal pay scale for well over 100 years. This committee has given us authorities for loan forgiveness. It's given us authorities for moving expenses. It's given us some authorities to raise salaries beyond what they would normally be. But that is an issue that is going to reach a point that we will have to come back and have a much longer discussion.
Thank you, Mr. Secretary. My time has expired, and with that, I yield back, Mr. Chairman.
Thank you, Mr. Boss. Mr. Levin, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and Mr. Secretary, to you and your team, thank you for being here with us, and on behalf of my communities in San Diego and Orange County, we thank you for your service to our veterans. I wanted to follow up as chair of the Economic Opportunities Subcommittee on one topic that my friend, the ranking member, Mr. Bill Rockus, brought up, and that's the HUD-VASH program, and specifically we've heard testimony in our recent subcommittee hearings on the difficulty in hiring and retaining case managers that are critical to operating the program. Studies have shown how effective HUD-VASH is at reducing veteran homelessness, but obviously without sufficient case managers, veterans can't access the vouchers, and that's certainly true as was indicated before. So what's the VA doing to address the case management staffing issue? And I heard the $30 million that you brought up before, but understanding a key challenge is recruitment and retention and offering a competitive salary for these case managers. Do we need to adjust the pay scale for HUD-VASH case managers, and if so, what would that require?
I think we've got room to move higher. Our problem primarily is in high-cost areas, as I mentioned before, but it's not just the cost of housing. It's the cost of living for that employee to stay in. We could use relief in our Title 38 authority for those social workers. One of the success stories that we've had in Los Angeles is to make that HUD-VASH voucher social worker part of an overarching team integrated with the rest of the medical care team. Much of the issues of our persistent homeless veteran really relate to chronic severe mental illness as well as drug abuse. And the full integration of those programs has resulted in much higher job satisfaction. Although one of the frustrations is we can bring people into long-term domiciliary care, but after 6 months or so, when we've got people drug-free and under good control, transitioning out is very frustrating into the community, especially in high-cost markets like you represent.
Thank you for that, and we look forward to working with you in a bipartisan way on trying to figure this out, whether it be the fair market calculation, ensuring that the voucher is commensurate with the actual cost of living in a particular area, or the eligibility criteria. We had legislation to expand that, and then the case managers, making sure that their salaries are competitive. So let us know how we can work with you. The other thing that we've done this year is we've made several visits to Muskogee, Oklahoma, and it's good to see you again, Dr. Lawrence, for the GI Bill call center regional processing office. We repeatedly heard the need for funding, and you went into that a little bit. But I was amazed that one such system is now over 50 years old, still in operation. And it seems to me that the budget request doesn't reflect everything that you need, and instead we seem to be left in this cycle of Band-Aids and IOUs for a system that's desperately in need of a revamp.
And Mr. Secretary, obviously, I hope you would consider education services, IT, a priority. And if so, how can we better reflect that priority, given that, VA, as my friend Mr. Lamb said, had their budget increased, one of only 2 federal agencies? How can we better reconcile the needs for the GI Bill IT infrastructure?
It is actually an issue beyond just the GI Bill, and is one that Ms. Lee has been very involved in, and that is a look at our entire IT infrastructure readiness. I will admit that VA has been underfunded on the IT front throughout the last several decades. We were right at the bottom. That is a bipartisan criticism, both Republican and Democrat administrations. So raising that IT infrastructure profile is absolutely the key. And moving things to the cloud, getting people away from actually having to touch a claim, that's what we're working on. And Dr. Lawrence, as you said, has done an incredible job at Muskogee, but we have a much larger issue than just the GI Bill, and we are working to correct that.
Thank you for that, Mr. Secretary. And again, thank you to the whole team. And I do hope, while this is an election year, things get a little crazy, that we're able to find those areas of common ground where we can work together in service of our veterans. I know that Mr. Bilirakis and I share that ideal in our subcommittee, and we look forward to addressing these and related issues. So thank you again, and I'll yield back to the chairman.
Thank you, sir.
Mr. Bergman, thank you, Mr. Levin. Mr. Bergman, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thanks to everybody for being here. We all sometimes hear the term, we're not in a sprint, we're in a marathon. I would suggest to you, this is not a marathon. This is not even an ultra marathon. More appropriately, I could maybe categorize this as a never-ending, multi-generational relay race in which the baton is passed from generation to generation, whether that generation be human or technology. Because as we hear what all of you have done on the technology side as we advance everything from the EMR to other digital technologies as we do our business processes, but also the generation of veterans, whether they be World War II, Korea, Vietnam, Desert Shield, Desert Storm, OIF, OEF, and going forward. Thank you for all the effort, both here on the committee side, but also on your side, to understand what is the baton we're actually passing. Because in some cases, it's going to be technology, but we can never forget the human side of that. Mr. Secretary, I've got a couple of rapid-fire yes or no kind of things here, so these would be okay. When this request was released earlier this month, Chairman Takano alleged that despite significant increases in VA funding overall and for mental health care and suicide prevention in particular, this budget would, quote, direct resources outside VA into grant programs and the Prevents Task Force instead of being used to explicitly support veterans in crisis at VA. Is that assertion true?
I don't agree with it, no, sir.
Okay. Is it true that most of VA's suicide prevention resources and efforts support suicidal or at-risk veterans inside the VA healthcare system?
Yes, sir, and if I can go beyond the yes or no, and the reason that is because something that the chairman has identified. 60% of those who take their lives we don't see. So yes, the majority of the funds are going internally because we're not touching those folks out there.
Right. So then is it true, despite tremendous growth in mental health and suicide prevention funding, staffing, and programs within VA medical facilities, that 20 service members and veterans die by suicide every day, and that 14 of those, as you just articulated, had not sought VA care in the 2 years prior to their death?
That's correct.
Okay. And is it true, based on VA's experience with choice and now with the Mission Act, that expanding access in the community leads to increased reliance on VA care, not reduced utilization or capacity?
Agree with you, yes, sir.
Okay. So now you've equated the success VA has had with respect to reducing the number of veterans who are homeless with the success VA hopes to have with respect to reducing the number of veterans who die by suicide to increase the success through the IMPROVE Act.
Yes, sir.
Could you please respond to those who argue that these two crises are, I'll call them mutually exclusive, homelessness and suicide are so different that the same approach could not and will not be effective in both cases?
So they're part of the same continuum. And the solutions for homelessness, where we have reduced to 38,000, have involved us getting into the community with partners to find those people who are homeless, those veterans that we don't see and we don't have the resources to go out and touch. That is the formula we need for suicide, in my opinion. Give you an example, the state of Alaska, most veterans per capita in any state, more than half have no contact with us. I have to go to the Federation of Natives in Alaska and ask them right now, without me giving them any financial support, to go out and please help us find those veterans we don't see in the wilderness.
Okay, thank you. Dr. Stone, just one quick one here. VHA has requested $270 million for the Office of Rural Health, OHR. OHR is authorized to develop and implement innovative and successful programs to improve care and services for veterans who reside in rural areas of the United States. How is OHR using its ability to innovate on behalf of our rural and remote veterans who might benefit from next-generation programs? Are we utilizing any new technologies?
Yes, this office has been one of the most creative and innovative offices within VHA as we seek to reach the remote and isolated veteran. Whether it is helping us in partnerships with companies like Walmart or helping us with our Philips partnership where we're placing self-contained units that allow us to do remote visits in VSOs around the nation. This office has allowed us to really fund creative and innovative ideas and really bring in partnerships like the major carriers that have helped us with the contact with veterans without costing text lines and cost against the veteran.
Thank you. And I see I'm over my time, and I guess as I listen to you talk, and when starting with the analogy of the baton, I guess each time we pass that baton, if we're doing it right, it's going to be a better baton, a more capable baton that we pass along to better serve our veterans. Thank you, Mr. Chairman. I yield back.
Thank you, General Bergman. Mr. Brindisi, you are recognized for 5 minutes.
Thank you, Chairman and Ranking Member, and thank you all, the panel, for your service to our nation's veterans. First off, I do want to add my voice to those who are calling for the VA to add additional diseases to the presumptive list for service connection based on Agent Orange exposure. But Secretary Wilkie, I wanted to ask you a question because last week the Undersecretary for Memorial Affairs, Randy Reeves, came to my district at my invitation to discuss the creation of a state veterans cemetery in New York. As you know, New York is one of the few states left that does not have a state veterans cemetery, so I appreciate him coming, and the district I represent in particular has about 56,000 veterans right now who are underserved by a state veterans cemetery or access to any veterans cemetery, national or state. We had a good meeting, and he, at that time, Undersecretary Reeves informed us that expansion projects are a top priority for them, and then the NCA works through new construction grants which meet the statutory requirements. I just want to ask, is your budget request enough to meet the needs of all top priority sites, both expansions and new constructions?
For the top priority sites that we have, and some of those are in New York, some are as far away as Utah and Wyoming, yes. I actually had this discussion with Leader Schumer about the concept of the cemetery in your district. We're going to make sure that the state of New York has every access to the grants that we give to help states on that. And you're right, that many veterans, it is a gaping hole in service.
Thank you. And I want to put a plug in for Undersecretary Reeves. He really has done a great job, and I could think of no person I'd rather see overseeing that program than him. He was fantastic when he came up to the district, so thank you for having him come up. I also want to ask Secretary about state veteran home construction grants. Your proposed budget includes level funding for state veteran home construction grants, and we have one such home in my district in Oxford, New York. I understand there's been a backlog of state grant requests, and Congress appropriated additional funds to address this backlog in fiscal years 2018 and 2019. Can you tell us what this backlog looks like now and how many of these grant requests already have state matching funds lined up?
I will have to get back with you on that. Oh, no, oh, John.
So I think you know in 2018 we received a plus up that pretty much brought the new construction backlog down. It was to about 70 million. We do have a sort of a static request now. Most of the so I think the backlog is going up from about 90 million to about a little right around 300 million. But most of that is for renovation, not for new construction. I think we eliminated most of the construction with the plus up. So that's sort of where we are today.
Okay.
Yep.
If I could
Dr.
add,
Stone.
sir, we have 154 state veterans homes that we're in partnership with. The Association of State Directors was in town here this week. We've been talking to them and discussing what the future is. We know that over age 75, there are 2 million veterans today. That will grow in the next decade to 3 million. We need the 20,000 beds that are in the state homes. We need to expand that. We have in our chronic living facilities about 45,000 beds. We need much more than that. And what you will see from us over the next 6 to 12 months is a development of an elder care strategic plan and a cognitive decline strategic plan that really begins to garner how to approach this. This also ties into the rollout of the caregiver program because most of those veterans would rather stay at home if they possibly could, and it's why all of this fits together.
Are you studying where across the country the needs are right now?
Yes, we are. As part of the Air Commission, we've taken a look at where the demand is. And one of the things we recognize, in spite of the very significant decline in veterans in the Northeast and the Northwest, those that are staying are substantially challenged and are engaging with us at remarkable rates.
Is that something that when you have the conclusions of those results, can you share that with us?
They will come here, yes.
Okay, all right. And then just finally, Dr. Stone, again, thank you for coming up to the district to visit the clinic in Bainbridge, New York. I appreciate your concern with service to rural veterans. And just want to talk just generally about the budget. And do you think there's enough in there right now to address the needs of veterans who are living in rural areas? What more can we be doing?
I think there's enough in here and we're comfortable with the budget. The movement of veterans has got to be tackled in the Air Commission. And you and I have had this discussion as we wandered around that great town of Bainbridge and met its citizens. And I appreciate the time you spent and your passion for this. But how we approach the future laydown of this system is going to require a recognition of the evolution of how we deliver health care in America. You know, we've grown to 2.6 million telephonic or face-to-face video visits last year. About 20% of our veterans will be working off of video visits, and they have some of the highest satisfaction rates of any of our visits. So I appreciate the ongoing dialogue that you and I are having on this. I'm not sure we're going to come to complete agreement, but we both want the same thing, and that is the care of the American veteran.
And I would give one more statistics. In FY19, more than 900,000 veterans had at least one episode of telehealth care. I hope that's bigger, that grows. I will tell you, my focus has been on rural and native populations. They serve in numbers greater than any other communities in the country.
Thank you all very much.
Thank you, Mr. Brindisi. Mr. Roy, you are recognized for 5 minutes, but if you need to get settled, I can call on someone else.
I'll go ahead and defer to someone if you don't mind.
Oh, yeah,
One round.
so I'll call Mr. Banks.
Thank you, Chairman.
Thank you, Mr. Chairman. Mr. Secretary, I was encouraged to see the President's budget proposal for the Office of Information Technology reflect the conversations that we've been having, both on the committee and in the VA about the importance of IT as the platform for more responsive, high-quality services for veterans. The $540 million increase, which works out to about 12%, is absolutely warranted. What will this funding level enable you to do in terms of particular IT systems and the veteran-facing programs that they support?
So it will allow us to focus. And in addition to the infrastructure readiness program, it gives us a map as to where we need to be. So it focuses on infrastructure, on cloud migration, decommissioning legacy systems, which you've heard some of my colleagues talk about. And I think the most important thing, and Ms. Lee and I have had a conversation about this as well, is recruiting the cyber workforce. I will admit that VA has been underfunded in IT. So the challenge is to catch up in those deficits, and that will impact caregiver and Cole Murray as well.
Let me turn to EHR for a moment. I'm interested in your thought process behind the new July 2020 date that you've already talked about a little bit for the initial go live in Spokane. How do you plan to use these additional 4 months to improve the system, most importantly, by pulling key capabilities forward into the initial capability set?
I think you've hit the two key points. There's a capability set, sir, that are in the capability set 1 that has to be developed and delivered by the vendor. But should we use the couple of months extra to take pieces that are in capability set 2 and draw them forward? Most importantly, online prescription refill. So 11,000 times a month, the Spokane market veterans refill online prescriptions. We were going to lose that capability in capability set 1, stand up a call center, do it all manually to impact that. But as we take these couple of months extra, the debate has been, is the interface well enough developed for our computerized pharmacies to draw that capability forward? And that is a recommendation that we hope to be able to recommend to the Secretary in what we call capability set 1.1.
Okay, that's helpful. Mr. Secretary, I do have to say I am struggling a little bit with the size of the with the requested EHR increase. It is a $1.1 billion increase over this year and a $400 million increase over the most recent FY21 cost estimate that I've seen. Let me say up front, I absolutely support the $90 million increase to accelerate the implementation of the scheduling system, but I have a hard time seeing how VA could even spend an $850 million increase for infrastructure upgrades. I wonder, Mr. Secretary, if you could unpack that for me a little bit.
If I may, sir, with permission of the Secretary, you see about $685 million in the budget for infrastructure development. We're moving from ancient cabling in these old buildings to 5E or 6 cabling. That is the majority of the improvement in the cabling of the buildings. Secondly, the control of heating and cooling in our switching stations in old buildings is about a $2.5 billion cost over the next 3 years, and that's what you're seeing in much of that increase.
And the greatest challenge, and Dr. Stone touched on it, is ancient buildings. I'm spending millions and millions of dollars building closets right now to house equipment because the facilities, some of which are 100 years old or older, cannot accept the kind of infrastructure that we need to get these programs online.
Mr. Secretary, with the time that I have left, I want to emphasize the importance of accelerating the scheduling system, as I noted a moment ago. I was disappointed with the original 5-year schedule, and the fact that your budget speeds it up to 4 years is definitely an improvement. But beyond words on a page, this means the VA medical centers in Indiana and Ohio are going to have a modernized appointment scheduling system in place next year. That is a big win, and I very much appreciate that leadership. With that, Mr. Chairman, I yield back.
Thank you, Mr. Banks. I now recognize Mr. Pappas for 5 minutes.
Thank you very much, Mr. Chairman. Thank you to our panel for your commitment, your unwavering commitment to our veterans. I really appreciate it. Mr. Secretary, I appreciated your comments about Mission Act, and I know in my district we are seeing already the ways in which Mission is improving outcomes for our veterans and opening doors of care, quality care for veterans across our state. That, of course, only will continue to work if our provider networks are adequate, and our networks will only be adequate if those providers are paid in a timely fashion. So I'm here to tell you that there is palpable frustration in the provider community in my own state. That has ebbed and flowed, frankly, over a number of years as we've seen different iterations of community care, so this is nothing new. But the Hospital Association in my state estimates $134 million in outstanding claims unpaid for community care. We had a hearing 2 weeks ago in the Oversight and Investigation Subcommittee, and Dr. Matthews told us that there are more than 2 million age claims in the VA system that she hopes to address by the end of this fiscal year. That is absolutely important. But in addition to that, we know that a number of the contractors with VA, these third-party administrators, also have, to be able to come to the table here to help solve this problem. So I'm wondering if we have your commitment to address this, to deal with these legacy claims, to make sure that our providers are paid in an appropriate and efficient manner, and that we can allow Mission Act to flourish.
Absolutely. Without it, Mission Act does not work. I can tell you that since Mission came online, we have adjudicated 11 million claims just from Mission and dispersed about $3.5 billion. But the legacy and catching up with the legacy is absolutely vital, or we will start seeing a reduction in that 880,000 number when it comes to partners that we have.
Sustainment of the delivery system and the contracts that we have with providers. We've taken a look at a number of rural areas. We have a higher penetration with our third-party administrators of contracted providers than does Medicare in many of the markets. We can only sustain that if we pay people on time. And what Dr. Matthews related to you last week in testimony is exactly where we want to be. I can tell you that this month alone, we've reduced our backlog by 200,000. And so I'm pleased at the direction that she's going. It's a promise we made to the Secretary to really correct this. It is one of the most frustrating areas for all of us, but part of this has to do with growth. Part of this has to do with just getting rid of antiquated processes and moving to what needs to be done, and that is pay people in a timely manner.
And there are a number of issues certainly at work here, from authorizations to IT systems, and we can really get down in the weeds on this issue. One of the things I wanted to find out from you today, if you feel that the budget is right-sized for community care and that we have adequate staffing within VA to be able to work with these providers on this issue.
So we do feel that the burn rate of dollars in this year's budget as well as future years' budget are right. However, we've got a lot of new benefits, and 3 months from now I may be up here giving you a different answer, but right now we look to be right on target of our burn rates for community care. And yes, we are staffed appropriately and have brought in adequate contractor support to support us with the processing of claims.
So my subcommittee has also done hearings on whistleblowers in the Office of Accountability and Whistleblower Protection. I know there's a significant increase in this budget proposal for OAWP, and I'm wondering if you could talk about your commitment to seeing improvements in this office, ensuring that the voices of these whistleblowers will be protected so that they can help improve outcomes for our veterans.
We are. There's a $26.5 million increase in the request for OAWP. And that also means we're bringing in more investigators. They received about 2,900 complaints last year, and right now there are 167 investigations going on. So that is absolutely key. The addition to that is I'm not simply relying on OAWP for accountability. We have released over 8,000 people. People who are not fulfilling their mandate. So we approach this from different angles as well.
Great. Well, thank you for your commitment, your work, and I yield back, Mr. Chairman.
Thank you, Mr. Pappas. Mr. Roy, you're recognized.
Thank the chairman.
5 minutes.
Thank the witnesses for being here today. Thank you, Mr. Secretary. Yesterday, I had the privilege of going over to Asper over at HHS to visit with them about what's going on with the coronavirus. It's been raised a couple times in here, but I'm correct, right, that the VA has a presence over there as well in ensuring that we're doing what we need to do in coordination to deal with the coronavirus.
Yes, we do.
They're an active part of that discussion and debate.
We're part of the task force.
And that's good. Let me ask you a quick question, because we've got limited time. Are you familiar in general terms with the overall budget submitted by the president? I know obviously specific to VA, but in broad terms?
In broad terms, yes, sir.
Well, the reason I ask is because there were some charges made earlier about what's happening to the other parts of the budget. And we're here obviously to talk about the VA budget. We want to make sure it's robust to accomplish the objectives. As I often say when I'm in the district, I'm proud to represent Fort Sam Houston, represent Army Futures Command, about 80,000 odd veterans and outside of military, City USA, San Antonio. You know, when I'm talking about it, I talk about that we want to make sure our men and women in uniform have a clear mission, the tools to carry it out, and the care when they get home. And so we want to make sure that's done here. We're talking about the entirety of the budget. Would you agree, at least based on your understanding of the budget, that what the president's budget submitted would balance in 15 years, within 15-year window?
That is my understanding, yes, sir.
And that in doing so, it does assume certain growth rates, 3% growth rates, and relatively low interest rates. In other words, it's still pretty aggressive in order to balance in 15 years. You have to have a massive economic growth in order to achieve that objective. Is that a fair statement?
Yes, absolutely.
In other words, we have a massive problem to deal with right now. We're racking up $110 million of debt an hour. We've got over $1 trillion a year that we're piling on, and we've got $23.4 trillion of debt. Those numbers sound roughly correct?
Yes.
Are you aware of any budget being yet proposed by the House Democrat majority?
I've got to be honest, I haven't followed that. No, sir.
Okay. Well, I'll tell you, I've not seen one. And was just walking over to oversight, ran into some. I couldn't go to a budget committee hearing this morning. We had director vote in a couple weeks ago. No one in the budget committee is talking about a budget being presented by House Democrats. So I'm rather intrigued by all the complaints about what's going on. When we talk about cuts in Medicare, I'm looking at the numbers presented by the president's budget, $722 billion for Medicare in 2021, going up to $1.269 trillion in 2030, increasing every year in between. Social Security, $1.1 trillion in 2021, up to $1.9 trillion in 2030, increasing every year. Medicaid, $448 to $607, increasing every year. What we have are savings measures being put in place on the margins to not impact benefits that are, frankly, in line with proposals put forward by the OMB under President Obama. Does that sound right to you, based on what you understand of what the president's put forward, or can you comment?
I can. I didn't follow budgets in the last administration.
Okay. Well, that's what my understanding is, having served on the Budget Committee and asking these questions of members that have come before the committee, that these are the numbers. So when I hear the sky is falling rhetoric about what we're doing with respect to cuts in other areas, I want to be honest, okay? Because there are not cuts going on to Medicare, Social Security coming from the budget from the president. The budget's put forward by the president, frankly, in my view, is not aggressive enough in what we need to do for the fiscal health of this country. We need to do a better job to figure out how to get to balance. Our kids and grandkids deserve better than $23.4 trillion of debt and climbing. And so I would put all of that in context to say that we're here with a robust budget for the VA in the context of a budget that was proposed by the president that balances in 15 years. And so I'd like to hear from my colleagues on the other side of the aisle something where we're working together to try to achieve that or improve upon it. Let me ask something. So do you have a comment?
No, I would just say that this budget, I argue, reflects confidence in the direction that VA is headed. We are in a position that this department has not been in decades. Confidence, the satisfaction of those veterans who use us, modernization of all of our programs. So this is a validation of the good work that all of our people are doing.
Well, I appreciate that. I've got limited time left. Let me ask one last question. With respect to choice and mission, I'm a big proponent of what we're trying to do there in community care. Upwards of 33 million now served through those programs. It's great. I get a lot of positive feedback. But the one problem we get whenever I talk to veterans is, health records and the clunkiness of sort of moving in and out of the system and going to community care. So what can you say about this budget request, and specifically, it's a pretty big jump in the technology dollars and so forth. What can you do to tell us that you're going to solve the problems that many of our veterans are facing using health records to move in and out of the system to use community care? Thank you.
We are on schedule, sir, and with the chairman's forbearance, I would say we're on schedule to roll out the Health Information Exchange, which brings 225 vendors and systems of health services into a integrated, interoperable electronic record system within the next 6 to 8 weeks.
Interoperability is the key.
All right, thank you, Mr. Roy. I now recognize Ms. Lee for 5 minutes.
Thank you, Mr. Chair. Thank you all for being here. And before I get into my questions, I just want to briefly talk about the postponement of the EHRM project. And I think we've all had those conversations on how we anticipated that this was happening. And I think from an oversight point of view, you take a serious risk in terms of being okay with postponing. So I just hope that we continue to have a transparent update, especially as the Health Information Exchange goes live. I'd like to have an update at that point, as well as on June 5th when you have your
Yes, ma'am.
mandate, your assessment date on that. And then finally, just highlighting that giving your practitioners the power to come to you and the freedom to be able to say, we're not ready. Also, again, understanding there's certain balance as well of at some point you just have to sort of rip the Band-Aid off and move and with what you have. So understanding that ultimately veterans care is important, making sure we're just in constant conversation about that and understanding what's going on would be greatly appreciated. I want to talk about the VA infrastructure modernization. It's a department-wide investment. Each administration and office in the VA has to play the same role in assessing the needs and whether some level of contribution is required. For instance, in the case of funding infrastructure for EHRM, the maintenance and regular refresh of that infrastructure and related physical infrastructure investments, OHERM, OIT, and VHA have a responsibility. However, there's little to no transparency in the budget that was submitted that clearly lays out how much of an investment is expected to be made and where the money's coming from. And without that transparency, there's no way to assess that the $1.2 billion OEHRM investment in infrastructure is going to get us where we need to be. So the question is, at least in the case of EHRM, did OEHRM, VHA, and OIT sit down and hammer out the infrastructure investments, including refreshing that infrastructure during the implementation period and non-recurring maintenance, and come up with a number and a plan?
I can answer that. And the answer is yes, they did. In fact, we made a transition from the infrastructure piece being partially funded by IT and partially funded for EHRM, putting it all in EHRM. They have teams doing infrastructure assessments, and the modeling is the costs are based upon those models. So, and we can actually walk the budget numbers much more granular to actually just specific sites.
Great. I would just like to see the number and the plan.
Yes, ma'am.
I want to go on and talk about the budget includes the $1.18 billion for infrastructure readiness for EHRM, additionally $1.85 billion in non-recurring maintenance. How much of that $1.18 billion infrastructure improvement would be needed, is needed outside of EHRM to fully modernize VA's infrastructure? Just really put it more simply, if there wasn't the EHRM project, how much of this would be needed to bring the VA to an acceptable level of technology?
I could answer that as well, and I would say all of it, and that is infrastructure, as I think as the Secretary mentioned, to upgrade communication closets, and when you see some of them, you'd be, truly shocked. And in fact, there was one anecdote that after the upgrade, I think it was at Spokane, the infrastructure upgrade with the technology, they were able to change login times from something like 30 minutes to like 15 seconds. I mean, it's that significant.
Okay, great. Just one final thing on the VA's ITOP EHRM alignment. The department plans a full transition to eradicate the cumulative technical debt in 4 years, which I completely appreciate. Based on this alignment plan, a significant number of systems, especially the endpoints, upgraded in 2021 would be scheduled for replacement in 2025. Looking forward, will OIT be absorbing the cost of future updates, upgrades, refreshes of technology that was originally funded through OEHRM or VHI?
So we're looking actually at a different model where we shift to sustainment of certain things being borne by the user. We have a working capital fund. So I guess if we could take that as a TBD, we're looking at various models of how to fund sustainment and then the refresh going forward. As it sits today, OIT would, but I'm not sure that that'll be the case going forward.
Okay,
Yeah,
great.
Thank you. Mhm.
All right, thank you very much.
Thank you, Ms. Lee. Mr. Muser, you are recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you all very much, Secretary, Undersecretaries. Thank you also for your significant progress over the last several years. It's really been quite remarkable, frankly. A few years ago, we were talking about all the issues facing the various VA hospitals and administration as a whole, and now we're talking about if the funding is in the right arenas so as these improvements can continue. Just a quick list that I have here of some of the progress and successes. Significantly improved veterans' trust in the VA. Were there surveys done in that regard?
Yes, sir. We survey our veterans. We also survey our employees, and why that is important. And I preach customer service, but I start off with customer service internally. If you don't have employees who are enthusiastic about coming into work, they're not going to give service to those they are supposed to serve. So we have all employee surveys. That's why we have risen from dead last, 17 out of 17, to number 6 in terms of best places to work.
I see that. That's terrific.
And the VFW, one other thing, sir, I apologize. The VFW just did its national survey of its many millions members, 90% satisfaction. And also, those 90% are recommending that those veterans who do not use VA come into the system.
Okay. Again, terrific. Near record low veteran unemployment. We do hear that. Any comment on that?
Yes. It is one of the best news stories in the country that is underappreciated. I have been able to go to the largest companies in the country as well as mom and pop shops and preach that veterans are the best value for the buck, particularly our young veterans. They can come in and look you in the eye and talk to you. They have also probably made those who have stayed in the service to the age of 25 or 26. They have probably made more life-altering decisions in their short lives than most Americans make in a lifetime. And that is an incredible benefit to employers at whatever end of the industrial spectrum they are.
Again, outstanding. Expanded access to care in VA medical facilities and the community, as well as gave veterans more choice and greater control over their health care. Certainly that was the mission of the Mission Act. Is that proving to be as effective as you would have liked?
It is. But I want to talk about a balance. It has been effective. We have put veterans at the center of their health care. If we can't provide what they need, they have the option of going into the private sector. Where we have seen the increase in traffic outside of VA is for specialty care, unique specialty care. But on the other side, we have also seen record numbers of appointments within the VA. So people are voting with their feet. They want to come someplace where people understand the culture and speak the language. So it's created, I think, a wonderful balance in terms of our ability to serve veterans.
Yeah, great. Do you see a hybrid being the model, if you will, moving forward?
Congressman, absolutely. There are, just with the remoteness of our population, with the geographic dispersion, there will always be VA at the centerpiece of care integration, but the utilization, when appropriate, of commercial healthcare systems to support. You know, today we will see 315,000 veterans. We will buy about 80,000 visits in addition to that. But 60,000 of those visits that will occur today are same-day visits inside our system. In addition, there are 440 veterans that are seeing their primary care doctor that'll have a warm handshake and handoff to mental health on same-day visits. 110,000 visits last year were done as mental health same-day visits.
I've limited time, so I want to jump to this question. Access and transportation has been a concern of mine, and I think would have great benefits from our suicide problem, access to health care. Certainly the hybrid model, gaining benefits and services within the community has helped. What are we doing as far as assuring that our veterans can get to the VA facility?
Number one, we appreciate the VSOs that are helping us with that, with volunteer drivers and donated vehicles. We're also working with Walmart Corporation and the VSOs to get into communities, both with direct face-to-face and remote visits. We've been working with Uber and Lyft to help fund, in addition to our beneficiary travel programs. We're looking for any sort of innovative way to help the compromised veteran that can't drive on their own to get to us.
Okay, I'll follow up with you. Mr. Chairman, I'm over my time. I apologize. I yield back.
Thank you, Mr. Muser. Mr. Cisneros, you're recognized for 5 minutes.
Thank you, Mr. Chairman. And thank you, Mr. Secretary, and thank you all for being here today. Dr. Stone, I just want to follow up on something that my colleague, Mr. Pappas, asked about the community care staff at the medical centers. You know, you said they're staffed and they're fully staffed, but I just visited Long Beach Medical Center, talking to them about this issue, and I know other individuals have kind of had some of the same experiences when they visit the medical centers, that the community care staff is overworked. They have too much work going on. So what criteria are you using to determine that the community care staff is fully staffed?
It's really the staffing model that the Assistant Undersecretary has brought to us that we created the budget from. But let me say this, I think you can find areas in this country that are overworked. I think you can find other areas of the country that we're doing pretty well. But we have seen substantial growth in specialty care in the community. What we're not seeing is that kind of same growth in primary care or mental health, as the Secretary has referenced. But I'd be happy to take a look at that market and see if we're off kilter, and if we are, we will staff it up. We have adequate resources to staff to where we need to be.
And I would add, and I think Dr. Rowe would appreciate the comment, your area of the country, the chairman's area of the country, is exploding in terms of veterans population. Part of the need that you have identified, I believe, will be addressed in the AIR reports and the market assessments.
All right, and I want to ask about a couple other staffing questions. This one particularly regarding the Vocational Rehabilitation Employment Program. And I'm pleased to hear that, you know, you're reaching your goal, or you will soon reach your goal of 1 counselor to every 125 veterans that are enrolled in this program. But is that ratio based on a national number, or is it more local? So is every center, are there going to be some centers, especially in more metropolitan areas, where, you know, they're not going to have the 1 to 125 ratio.
Sure. So you're right. Last year at this time, when you and I bantered, we were in the process of hiring sufficient counselors to reach that goal, and we have. We've done both. We made sure at a national level and at a local level, we've shifted some things around. So like Dr. Stone pointed out, we're always monitoring that. That's required by law. We'd like to do some more study because as you and I talked in your office, this is one of the most popular programs that yields some of the best benefits for our veterans.
Right, and the one thing the concern I still keep hearing about, though, is the constant turnover of the counselors. They're being shuffled around. You know, a veteran is there, they work a relationship, they build a relationship with the counselor, and then, boom, that counselor's moved, and they don't even know, and then they're having to start all over again, kind of, you know, giving them their new information. I mean, why are we still kind of seeing this kind of turnover where people are constantly changing around and moving?
Sure. Since you and I talked about this, we've done several things. We've been, I think your feedback was one around the consistencies of the outcomes and all the counselors. There is sort of several things happen. One is sort of the kind of things you're hinting at, which is it shouldn't have happened that way. The other is, of course, very hot job market as a secretary. People leave us, we have to balance. And then we also do, in connection to your first question, we rebalance the load to get people more attention. So we try not to do as much of that as perhaps you're seeing.
Okay. And in the budget, Secretary Wilkie, it indicates that the Veterans Benefit Administration is going to relocate 166 full-time employees to the VR and E program. All these full-time employees focused are the employees focused on administrative help, or are some of these going to be counselors?
A little bit of both. We're trying to centralize some of the administrative tasks so that we can actually free up more counselor time, in addition, hire some more counselors.
So one other request I have, and if we can work this out, you know, I have several colleges in my district. A lot of them, veterans are attending these schools. One, Mount San Antonio College has MOU for the VSOC program. It would be great if we could build in these memorandums of understanding for the other colleges as well. It's a great service at Mount San Antonio College. But the other ones, you know, being based in Orange County, have to go to the LA VA in order to get that support, and they can't get it on the local level. So what grounds or what are we doing to kind of try and change this to make more local MOUs so the veterans can get local service?
The VSOC is one of our most popular programs. Every school is asking for it. We're looking internally. We started this a little while ago, a project to figure out where to find the resources to get counselors on as many campuses as we can. Happy to come talk to you about that.
All right, appreciate that. Thank you very much, and yield back.
Thank you, Mr. Cisneros. Mr. Stubbe, you recognize for 5 minutes.
Thank you, Mr. Chairman. I want to thank each and every one of you for your service to our nation and what you do for our veterans. Just as a quick bit of background, I served 4.5 years active duty, Operation Iraqi Freedom, 25th ID, did a tour over there. I'm a disabled veteran. I'm 70% disabled. It took me 11 years to go through the appeals process to get that designation. I've obviously been on this committee for over a year now and have reached out many times, Mr. Secretary, to your office. Still haven't been able to get on your calendar. So well, let me say something first, and then I'll ask a direct question. I have town halls in my district, and I have a very large population. I represent Southwest Florida of veterans in my district. We live, most of my district's in a very rural area, so the nearest hospital is like a 4-hour drive, 3.5-hour drive. Every town hall I have, both telephonic town halls and in-person town halls, by far, unequivocally, veterans issues are the biggest challenge in my district. I just had a town hall in person in Sebring. I would say 65% of the issues brought up were challenges that these individuals were facing with the VA, not good challenges that they were facing, not positive things. We had a teletown hall not too long ago, and one of the individuals in the teletown hall said that it took him over a year through the Charlotte clinic to get hearing aids. This is somebody that service-connected disabled. So there are a lot of issues that are affecting my district. My constituents voted me up here to represent them on these issues, and I would like to know who I need to contact to get on your calendar to talk about all these issues. Because quite frankly, 3.5 minutes is nowhere near what I need to go through the litany of things from the claims process that I've gone through personally, the appeals process that I've gone through personally, the healthcare issues that are directly faced in my district. We were supposed to have Sitterly come down. He canceled. We were supposed to meet with you in September. That got canceled. He was supposed to come to the district. That got canceled. It's been over a year. And I'm trying to serve my district. And there are real challenges in the VA. And we are blessed to have districts like the district in Ranking Member Rowe's district, where he's got a great hospital, a great facility, and the treatment for VAs is great. I'm on the opposite end of that spectrum, where we don't even have a hospital in my district. And we have a few scattered clinics, and those clinics can't handle anything. They bring in some things. The implementation of the Mission Act in some areas of the country has been tremendous. In my district, it has not, and there have been a huge amount of challenges. So I just want to know who I can contact in your office to sit down with you and go over these issues.
I'm happy to do it, and I wish I could answer as to why the schedules didn't meet up. But as evidenced by some of your colleagues, I've been in a lot of their districts. I'm happy to go. Family's in Tampa, so I'm close by. But no, just have your scheduler call my office and we'll get together.
Okay, well, we've done that several times, so that's why I'm asking you now again. I'll ask one very basic question that has come up, and it's related to third-party insurers. So, you know, all of us are interested in prompt payment by the VA of bills submitted by outside providers for community care. Do you believe that the VA also should be interested in collecting every possible dollar that is due to the taxpayers for services that are provided in VA facilities and covered by third-party insurers?
Oh, absolutely, yes, sir.
Do you believe that the VA should be utilizing the same collection procedures that private sector providers use today?
I don't know what the regulations would be, but your first question is right on target. We should be. So I don't know what the procedure would be.
Well, the numbers that I've seen, I mean, the graph is kind of skewed. Like the numbers of things that we should be collecting and that aren't getting collected by third-party insurers, I think would really help solve some of our budgetary issues that we face. So I just want to make sure, and if there's legislation that we need to do on this side of the chamber to make sure that that happens, I'm happy to work on that.
Speak to a little of that. I think one of the big challenges they have is people self-disclosing that they have other health insurance. I think some people feel like if I disclose it, my premiums are going to go up or something like that. Same thing we've experienced in the military health system. But I, as the secretary and have some experience with this, agree that we should absolutely pursue that. It's just a matter of how aggressively we go after it. And I don't know that we should employ all the commercial tactics. I mean, I think that we're dealing with the veteran population as well, so I think we have to look through that lens as well.
Okay. I thank you guys for being here today. I will follow up with your office. I would yield any remaining time to the ranking member if he has any questions. If not, I yield back to the chair.
Thank you, Mr. Stubbe. Mr. Sablan, you're recognized for 5 minutes.
Well, thank you very much, Mr. Chairman. Mr. Secretary, welcome. I apologize that I was not exactly friendly when you first walked in, and I have my reasons for that, Mr. Secretary. One of the goals of the community health care listed in the budget documents was to award and implement the new community care network contract in Region 5 and implement the new direction in Region 6. Region 6, of course, covers the Northern Marianas, American Samoa, and Guam, one of the highest enlistment per capita in the nation. The department's decision to run the community provider program for the Pacific Territories is described as a new direction. Mr. Secretary, when we met our launch, you promised me that you were going to do everything you can to help me. This decision has, in fact, Mr. Secretary, is a return to the old system, the ones which led to the change and the need for choice program. How does the department intend to ensure the problems from the old system do not come up again in this new direction for Region 6 veterans, for my veterans, for those in American Samoa, for those on Guam?
Sir, what we found was that in Region 6, there was such a low number of providers trying to get a third-party administrator to really administer that was ineffective, and we felt that we could serve the veteran population better by directly contracting with the providers that are so geographically dispersed across your area.
Thank you. You're saying that we're going to, but I'm correct, we're going back to the old system where veterans deal directly with VA.
I'm
And
saying
in my
that the
district, sir-
providers will deal directly with us
Sir,
in our delivery
okay.
system.
In my district, sir, we hired, or VA hired a social worker. It took VA longer to get that social worker to report to work on its first day than it took for that social worker to retire from his position. You know what I'm saying? It took your department longer to get that guy to come to work on his first day than when that guy had left because he's retiring. Now, that's the kind of service, sir, we're going to, I mean, you call that, you know, we take these young men and women, put on a uniform, send them off to war, and give them a promise that we will forever take care of them for their service. I hugged a veteran just last Thursday who is now home. There's nothing else that they can do for him. I hugged him. He has cancer. And he goes in and out of the hospital. He goes in and out to get his painkiller medication that are so powerful that they can't give it to him at home because it could be dangerous. I have many questions. So the reason given and is not enough interest to proceed. What exactly is meant by not enough interest to proceed?
The size of this market is so small as far as the number of veterans that are in it, that the third-party administrators, we felt we could administer better directly. Now, I am respectful of the fact that you know this market better than we do. And if you think that's a bad decision, we'd be happy to sit with you and talk through it. But our goal is the same, and that is to serve the veterans in this area. Both the Secretary and I are veterans. Both of us have had deployments. We understand the pain of this. But we felt that we could deliver care more effectively by directly contracting with your providers than going through a third party.
And I made a commitment to you, and I expressed this to the chairman, that my focus on the continent was Native populations, Native veterans, and then the Pacific. I visited Marianas, as you know, you were a gracious host. I promised you, and I promised the chairman, I have to be more creative. I have to be more creative in getting our partners in the Department of Defense out to the Marianas and expand also, and I spoke to the governor of Guam about this a week and a half ago, expand our VA presence in Guam as the Naval Hospital expands. So we're trying to be very creative.
Just, I'm so envious, you know, the gentleman here is complaining that he doesn't have a hospital, but he's got several CBOCs. I don't have a CBOC. I don't have a vet center. You guys were talking about programs, caregivers, and HUD VASH. Those are not available in my district because VA will not put staff in my district to take care of veterans who are getting old, who need hospice care, or who need people to come visit them at their homes. I've got nothing except for a fee-based doctor who's available twice a week to see 400 veterans, or almost 500. We have to figure something out better than what we're giving these veterans. Sir, when they put on a uniform, they're as much American as you are. And yet, when they get wounded and they go to the islands, no, they're only half an American. It's enough that they don't vote for their commander-in-chief, sir. Give him some decency.
Well, I have been very clear that the veterans of the Northern Marianas, Guam, and American Samoa serve in numbers in the armed forces greater than any other communities in the country, with the exception of Native communities in the continental United States. I have made a commitment to do as much as I can. Last thing about my last visit to the Northern Marianas, I looked at and talked with the hospital provider in your district, on your island, to enhance our partnership there. I've had long discussions with Indo-PACOM, the command out of Hawaii, to bring folks in, their people, their ships, to help with caring for veterans on your island, and also, as I said, expanding the closest large veterans facility to you on Guam to service veterans on both islands. So it is something I've worked on. I showed my commitment by coming to see you, also going to Samoa and also going to Guam. Hope to be out there again, but it is something that we're working hard on. I wish I could make it go faster.
Mr. Spahn,
my time is up, Mr. Chairman. Thank you very much, Mr. Secretary.
Mr. Secretary, I hope that I do grant your sincerity, and I know you've traveled there, and so has the committee. And I share Mr. Sablon's frustrations, and I know you're frustrated. I encourage you to engage with us on a solution.
And I agree with you, sir. Yes.
Thank you. Mr. Barr, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you, Secretary Wilkie, Dr. Stone, and our other witnesses for your service to our veterans. Obviously, with Mr. Sablon's line of questions and Mr. Stubbe's line of questions, there is work to do. There are problems, but I do want to just note for the record my appreciation and my colleagues' appreciation for the President's budget request. $243 billion, a 10.2% increase above the 2020 enacted levels. I'll note the testimony that you provided again that the VA's budget has increased more than $60 billion or 33% since 2017 under this administration's leadership. And the fact that the 2021 request would support 404,835 full-time equivalent employees at the VA, an increase of nearly 15,000 above 2020, more than and then more than 33% of those employees are veterans. I think that is an indication of the commitment that the Trump administration has to the VA, and I think it also dispels the myth that this administration is interested in privatization. I think that those basic facts run totally contrary to this narrative that somehow this administration is moving towards privatization. Clearly not. When you have that much of a significant increase in funding and employment at the department, and I appreciate this administration's promises made and promises kept approach to our veterans. But as my colleagues have noted, there are challenges that remain. As we all know, the opioid epidemic is an issue that has touched every community in the United States, and especially in my home state of Kentucky. According to the CDC, Kentucky is among the top 10 states with the highest opioid prescribing rates. I was encouraged to read your testimony, the efforts that the VA is taking to reduce the reliance on opioid medication for pain management. You note that alternative therapies like whole health that are important to components of the VA's pain management strategy. As you know, I've been a strong advocate of these alternative therapies like acupuncture, equine-assisted therapy, adaptive sports. And in the 21 budget request, I will note that unfortunately funding for the VA's whole health initiative did not increase, and neither did funding for the adaptive sports program. My question is, why is the funding stagnant if this is in fact an effective method of getting veterans off of opioids?
Sir, you've recognized accurately that we've led the nation in reduction of opioid use. Our actual opioid use disorder patients have actually, from 18 to 19, actually went down. We just had a session in which we took a look at the use of whole health in the reduction of opioids and other pain medicines, and found that if we added whole health techniques, Tai Chi, various cognitive efforts, yoga, what we found was an additional 38% reduction in pain medicines. Now, what you're seeing in the budget is we really believe it's time, instead of having this sitting off to the side, that we integrate into our PACT team models, our care team models, the capability to do this work. And that's where, although you see it's stable in the budget, It is actually a reflection of an evolution in how we're approaching whole health techniques.
Well, thanks for your efforts on opioid avoidance, and just note for the record my interest in the whole health and the adaptive sports and all of those alternatives. The appeals backlog. Obviously, we appreciate the $24 million increase for the Board of Veterans' Appeals above the 2020 enacted budget. We know that you have good intentions to address the pending legacy appeals, but I will tell you from my casework that despite the Appeals Modernization Act, and it has helped, we know that Appeals Modernization has helped. We still, though, have a problem with the legacy appeals in our casework. We're seeing 3-year delays. Can you tell us what is the biggest factor causing that delay? And what are we learning, and when are we going to get to those legacy appeals, because that's impacting my veterans?
Sure. The Appeals Modernization Act, as you point out, is a great success. So let me sort of talk a little bit in the details. Over at the Veterans Benefits Administration, we process legacy appeals, and those are generally resolved, but some can go to the Board of Veterans Appeals. The increase you describe is for more judges and more support to actually process their way through that. So we are experiencing the last sort of part of the new beginning, if you will. You're right, this is a big focus. I know that the board is thinking about not just in-person hearings, but telehearings and every kind of way to work that off. I believe they said this will be done by 2022, but I'll be happy to arrange for them to come and talk to you about it. But they know this is a very important effort.
Thank you. I'm over my time, and I appreciate your service and your work. Yield back.
Thank you, Mr. Barr. Ms. Underwood, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you, Mr. Wilkie, and everybody for joining us today. In the last 20 years, the number of women veterans coming to the VA for health care has tripled. This includes mental health care. And in the next 20 years, that number is projected to double again. Too many American women are struggling to get quality, affordable health care. Gaps in our healthcare system and our healthcare workforce are a big contributor to that. Finding and retaining staff is a challenge across the system at large, and it includes the VA. So Secretary Wilkie, VA staff shortages for gender-specific care are a concern, and one that you all outlined in your budget request. Will this budget get us to a place by the end of the year where the gap between supply and demand is closing, not continuing to grow?
I do believe it will begin to close. We in this last fiscal year just trained 7,000 more healthcare providers for women-specific care. We are seeing, we now have 2 healthcare professionals in each of our centers who deal specifically with women's health. So that's part of the change. I do expect that the percentage of women veterans who are coming to VA to grow. We're now thankfully up to 41% enrolled, 84% satisfaction rate of the women veterans who use VA. It's a massive cultural shift. Be real quick, when I was born, my father was in an army that less than 0.5% were women. As the Undersecretary of Defense under General Mattis, I was responsible for a force that was 17% women for VA. That means 10% of our population.
So, sir, you said 7,000. You were training 7,000 clinicians, I'm assuming?
Providers and nurses. Yeah.
Okay. And so they are general practitioners, not to be offering gender-specific care. Is that correct?
They are providing gender-specific care in many residencies. Let me give you an example of that. As part of this budget, we will train 450 mental health providers in gender-specific care for women veterans.
Right. I guess what I'm trying to delineate between is a general practitioner who might take care of women versus someone who is there to take care of women for their whole FTE.
So as we grow, we will, that's why we're doing the mini residencies of repurposing the workforce. There is not a gender-specific workforce out there that we can effectively hire, and therefore we're training ourselves to get there, and we'll rededicate that workforce as we get there. Let me give you an example of that. We make the diagnosis of breast cancer about 500 times a year in the VA. We have about 2,900 active breast cancer patients.
Right.
Those are dispersed across the system so much that I can't have a dedicated full-time breast cancer surgeon, and a lot of that work goes out.
Okay. The VA is required to ensure that all women veterans that you have and you serve are assigned a women's health primary care provider, but right now only 78% have one. Will the budget close that gap by next year?
Yes.
Okay. The President's recently submitted a supplemental appropriations request to respond to the coronavirus. This package does not include any specific funding to assist VHA facilities in the event that they need to respond to COVID-19 cases. Given the diverse population of patients the VA facilities interacts with on a regular basis, it's obviously something that we need to ensure that we're planning for. Secretary Wilkie, what steps is VHA taking to ensure that veterans have the information that they need to keep themselves and their families safe?
Well, thank you. VA is the foundational response force for national emergencies. Every year, we prepare and deploy for hurricanes, for earthquakes. We regularly train for outbreaks of viruses, medical emergencies. We don't need any extra money now.
Sir, I'm not asking about the money. I'm asking about what are you doing to share the information with the veterans and their families?
So we are subordinate to HHS in communication with the American people, and we have not gotten in front of that. We have had a series of missives that we've sent to our workforce, as well as we have been rehearsing all of our response systems, but we have not directly communicated to the American veterans separate from HHS.
Okay, so even if it's not going out under a VA letterhead, have you sent anything to the veterans in your care about coronavirus?
No.
No. Okay, is that something that you all are planning to do in the weeks to come?
As we watch this and respond to this, yes.
Is that something that's been part of your plans for pandemic response that would include direct response from the VA as their provider to that veteran that they serve?
Yes, and this is part of a response that goes back to Ebola.
Right.
In the early 1990s, each of our hospitals has a response system that includes communication with veterans. Now, let me correct my answer just slightly. We just had a discussion with a number of the VSOs yesterday or day before regarding this and what we were doing and what we needed from them when we begin directly communicating.
So, and to add to that, because we have been through these things before, we are looking at our supply chain, we're looking at our processes to prepare in the event that we are called on.
Okay, I know my time has expired, Mr. Chairman. I would just like to urge you to recognize that we are on the precipice of a significant public health crisis in our country, meaning the arrival of coronavirus at pandemic levels in the United States. You all know as well as I do that the VA is the primary care provider for a lot of individuals, and your providers are the trusted healthcare source that these individuals are interacting with. And I would urge us to take a proactive public health response to manage that risk communication. They're not going to get it from anywhere else, and so let's not hide the ball here, sir. Thank you. I yield back.
Thank you, Ms. Underwood. Mr. Stubbe, you're recognized for 5 minutes. Oh, Ms. Watkins. Watkins.
Yes,
sorry.
Mr. Chair, that's all right.
My-
Well, that's okay. Thanks all for being here. And like Mr. Stubbe, I'm also a disabled veteran, and I receive my health care through the VA. So I got a bone to pick with y'all. And I say that lovingly. I got a surprise bill, and I was referred to community care outside the VA system in my home of Topeka, Kansas, to a hospital called Stormont Vale. I know Stormont Vale well because my dad's been a doctor at it for 40 years. He's also been on the board of directors of Stormont Vale. The VA, I know all those people quite well. I've lived in Topeka almost my entire life. And I don't know how to solve this thing, man. I have called and sat on hold and for 25 minutes at a time, then been bounced around to other recordings and things like that, and I can't seem to solve this surprise bill. And imagine that, because I know the VA system well. I know my doctors in the VA system well. This is my community. I've been a member of the greater Topeka medical community for my whole life since I was 6. I was referred to Stormont Vale, where my dad's on the board of directors. My dad is an endocrinologist, the very type of doctor whom I saw. And there's the surprise bill. I can't solve it. And I'm in the United States Congress. Moreover, I'm in the VA committee. And the subcommittee that deals with electronic medical health records. And so I don't say that to make you feel uncomfortable. I say that because we're users of these systems. We're not in a bubble. Just like Greg said, I mean, we're dealing with this personally ourselves, and it's one fight, and I thank you for continuing that fight. We've got a long way to go. Mr. Secretary, good to see you again, sir. The President's budget request of $90 million more to expedite the implementation of the Cerner scheduling system. I think it's great. The medical centers in my district were slated to get the new system in 2025. We had a hearing about scheduling implementation last year, and it's clearly a great system, a much better improvement over Vista. With this acceleration, when can Eastern Kansas expect to see this modernized scheduling system?
You know, the goal is to have scheduling components by 2024, all in place.
All right. The VA has invested a significant amount of taxpayer funding to develop a modernized claims processing system for the Board of Veterans Appeals called Case Flow. What is VA's timeline to sunset the board's legacy system?
We don't have anybody from the Board of Veterans Appeals here with us today. We can arrange for follow-up to make sure you get the information.
All right. And that's all I got. I yield the remainder of my time. Thanks for your efforts.
Thank you.
Thank you, Mr. Watkins. We are coming to the conclusion of Panel 1 testimony. Mr. Secretary, I want to thank you for appearing before this committee to testify on the budget. But before we leave, I do want to reiterate Ms. Underwood's plea that the VA look carefully at how we prepare for a impending public health crisis, that VA does have a fourth mission, which is not just about our veterans. It's also about, as you said, being there for national emergencies. And this, I think, is emerging into a national emergency. And we ought to think, Dr. Stone, you talked about standing up our testing capacity, and I think we will discuss this more. But before you leave, I do want to address another important issue, and that's the issue of sexual assault and harassment at our various VA facilities. We do need to make some cultural changes to improve the care and of our women veterans, and to make them feel welcome. And making the cultural changes necessary to make the VA an inviting place for our increasing number of women veterans will require leadership from the top. 1 in 4 women in the military experience military sexual trauma during their service, and at least 1 in 4 women veterans experience sexual or gender-based harassment at VA facilities. And just because a medical center has a low complaint rate from women veterans, it doesn't mean that sexual harassment is not occurring at those facilities. It may mean that women just don't feel safe and comfortable coming forward. It's counterintuitive that we may actually, in the interim, in the short term, actually want to see more complaints being lodged at our medical centers. And these are some of the issues that I hope that we will discuss at a future planned hearing, a hearing that I plan to schedule on this topic. What I want to know from you, Mr. Secretary, is will you commit to working with my staff to ensure that you personally appear at this hearing?
Oh, yes, sir.
Thank you, sir. I appreciate that. With that, the first panel is excused and ready to bring forward the second panel. Thank you. We will take a brief bathroom break, 5 minutes. A recess, and people may do what they want to do on this recess for 5 minutes. if we could take our seats, and I'd like to get panel 2 started. If panel 2 could take their seats. I'd like to call the committee back to order. And is Melissa here? She's still. She just stepped out. Okay. Adrian's here. All right. I now invite our second panel to the witness table. We have seated at the witness table Mr. Adrian Atazzato, Deputy National Legislative Director of Disabled American Veterans on behalf of the Independent Budget, accompanied by Mr. Carlos Fuentes, Director of the National Legislative Service of the Veterans of Foreign Wars on behalf of the Independent Budget, Mr. Morgan Brown, National Legislative Director of the Paralyzed Veterans of America on behalf of the Independent Budget. And I know that Melissa stepped out, Melissa Bryant, the National Director of the American Legion on behalf of the Independent Budget, and I expect Melissa to take her seat shortly. But let's get this going. Mr. Atazzato, you're recognized for 5 minutes.
Chairman Nakano, Rank Member Rowe, and members of the committee, the co-authors of the independent budget, that would be DAV, PVA, and VFW, we are certainly pleased to present our fiscal year 2021 funding recommendations for the Department of Veterans Affairs, including advanced appropriations for fiscal year 2022. I heard a little bit of discussion earlier with the first panel about the increasing resources that is going towards Department of Veterans Affairs. Now, I understand to the untrained eye, the overall veteran population is decreasing in light of the increasing amount of revenue, or I'm sorry, resources going to VA. But as we all understand, the public may wonder that why VA's budget in fact continues to increase. Simply, it's just that less than half of all veterans come to VA for their earned benefits. And for those that do, their numbers increase year over year. And the investments made in VA represents a continued commitment to care for those veterans, as they've honorably served and sacrificed in defense of our freedom. Our own fiscal year 2021 budget estimates affirm that these needs continue to grow. The IB recognizes the work done by Congress to secure stable and predictable funding for VA by appropriating in advance $91 billion in discretionary dollars. We would like to recognize the administration's budget request for VA, which provides 13% increase, which is fantastic. But unfortunately, when we review this request, we believe it does fall short in meeting true needs of America's veterans in light of pending requirements that Congress has put on VA and other requirements VA is putting on itself to serve our nation's veterans better. For fiscal year 2021, the IB recommends $114.8 billion in total discretionary budget authority for the VA. This recommendation is $4.4 billion more than the administration requested, and it's about $17.3 billion more than the current fiscal year that we're in, 2020. Most of this increased funding recommendation go towards veterans medical care, about $13.6 billion of that. Of this increase, about 85% or $11.8 billion would go towards in-house VA care. This large increase is driven by our current services estimate reflecting the impact of projected uncontrollable inflation on the cost to provide services to veterans that are currently using the system. The estimate also assumes the baseline 3.1 pay raise, which Congress enacted back in December of 2019, and a projected increase of about 65 new enrollee and unique patients. We also recommend an additional projected medical funding needs for VA of nearly $2.1 billion for a handful of programs, including VA's prosthetics and sensory aid service, the Women Veterans Health Care, VA's Comprehensive Caregiver Support Program, and to close the gap on VA's reported vacancies for outpatient mental health and primary care. VA's construction accounts is another major VA account. The IB recommends additional funding. We recommend a total of $3.9 billion, which is a $2.1 billion increase over current funding levels to address serious construction needs. Finally, the IB is recommending an increase of $1.2 billion to continue developing and deploying VA's electronic health medical record, and separately deploy a new VA scheduling system in advance of the 5-year that's been portrayed. We'd like to see that scheduling system come out faster than is being requested, simply because not only does it provide operational efficiencies, it provides a lot of satisfaction and less turnover rate for the facilities and the VA staff that use that system. Chairman Nakano, Ranking Member Rowe, we recognize the administration's budget request contains numerous legislative proposals, and the IB would like the opportunity to work with you and your staff as the committee considers each of these proposals to ensure veterans' interests are at the forefront. For example, the IB opposes 4 benefits-related proposals that would reduce benefits or limit veterans' access or their survivors' access to their earned benefits. Other proposals, though, we support, such as the one regarding VA's medical foster home program. This concludes our oral statement, and on behalf of the millions of veterans the IB VSOs represent, we want to thank you for this opportunity to testify. My esteemed colleagues from PVA and VFW are happy to answer any questions you may have.
Thank you, Mr. Adesato. I now call upon Melissa Bryant for 5 minutes.
Thank you, Chairman Takano, Ranking Member Rowe, and on behalf of our National Commander, James W. Bill Oxford, and the nearly 2 million members of the American Legion, we thank you for the opportunity to testify on the Department of Veterans Affairs fiscal year 2021 budget. As VA moves forward to serve the veterans of this nation, it is imperative that the Secretary have the tools and resources necessary to ensure that veterans receive the services they are entitled to in a timely, professional, and courteous manner, because we've earned it. The American Legion calls on this Congress to ensure that funding is maintained and is increased as necessary to ensure the VA is preserved and enhanced to serve the veterans of the 21st century and beyond. I'm going to go off script a little bit to reiterate, for one, comment that has been repeatedly brought up throughout the first panel, and that was the Agent Orange presumptives, and reiterate that the American Legion supports for these Agent Orange presumptives to be given to these veterans who are waiting, because one of them is my father. And that's something that I continue to use, I should say I share with the Secretary in having a Vietnam veteran era parent, and knowing that his exposure to Agent Orange through his injury by punji spikes through his legs is something that we know is traced to these ailments, and my father being one of those veterans impacted by those Agent Orange presumptives, we urge for OMB and for others to ensure that those are tended to. Beyond that, within our written testimony for the American Legion, we also speak to the 17 points that have also been talked about throughout today's hearing to include mental health provisions for suicide prevention, for PTSD, for TBI, and of course going all the way through to women veterans like myself, and ensuring that we have the gender-specific care that we require provided to us by the VA through our earned benefits. I won't belabor into those points into the interest of time, but I want to say that the American Legion appreciates the leadership of this committee and remains committed to ensuring that the VA has the necessary funds, the resources, and the staff to carry out its mission of caring for our nation's veterans. And we're committed to working with the Department of the VA and the committee to ensuring that we're provided with the highest level of support of care. And with that, in the interest of time, I'm going to conclude my oral statement so we can move into questions and answers. So thank you, gentlemen, for your time.
Thank you, Ms. Bryant. I'll recognize myself for 5 minutes, and I want to quickly get into questions. I'm sure all of you have seen the $53 million requested, the $53 million requested by the administration for the Prevents Task Force in fiscal year 2021. Just very quickly, yes or no, were VSOs appropriately engaged by VA in the Prevents process? Mr. Adesato, I'll begin with you.
Well, Mr. Chairman, I can tell you that the last few meetings at the White House on the Prevents Task Force, we have not been invited, although we have been engaged with Dr. Van Dalen on her efforts.
Okay. Yes. Mr. Fuentes?
VFW Executive Director Vijay Wallace is on the Prevents Task Force, and we've been involved with the task force. No direct feedback on the exact monetary amount that they're requesting, though.
Yes.
PVA has been invited and participated in the meetings, so we have had some opportunity to make some input.
Ms. Bryant?
Likewise, the American Legion has been invited to the Prevents Task Force meetings. We have provided advice and counsel, nothing further.
Very quickly, what is your understanding of how these funds, these $53 million, will be used? And do you know if your recommendations will be reflected in the final Prevents Task Force report released in March?
Well, Mr. Chairman, I couldn't say either way until we actually see what the roadmap is and how that translates down to the different linkages across agencies and secretary's priorities. We couldn't make any kind of commitment at this point, I think.
Go ahead.
Same for the VFW, we'll have to evaluate, but it looks promising.
Same for PVA.
Likewise.
Great, thank you. The independent budget notes that institutional cultural change from the top is necessary to create a welcoming environment and ensure high-quality care for women veterans. In your opinion, what actions should VA take that it is not currently taking to facilitate this cultural change? Why don't we begin with Ms. Bryant?
To your comments earlier, Mr. Chairman, we believe that the VA needs to seriously consider its end harassment campaign, and starting with setting that cultural competency for women as we enter the facilities, in knowing that we are welcomed and knowing that our services is recognized. So that's something that VA, one, needs to continue to enhance. Appreciate the Secretary's comments earlier in that they're looking at their bystander policy and how they would continue to help those who are perhaps feeling uncomfortable within the main spaces of the VA. We appreciate that the care that is provided in the women's clinics is outstanding, depending on the facilities that you attend, such as the DC VA where I attend. However, we also know that all facilities are not created the same, and so ensuring that we're not harassed in other parts of medical facilities, doubling down on the end harassment campaign, doubling down on gender-specific care, not so much general practitioners who provide pelvic exams or anything else that would be for a woman, but more gynecologists and those who focus on gender-specific care. Those are the steps that the VA needs to continue to push upon.
Anyone else would like to respond?
I would like to add as well, this committee and this body has passed the Deborah Sampson Act, which will significantly improve care for women veterans. The Senate needs to do that. And we're hopeful to work with you to secure Senate passage. Also want to add, let women veterans choose the gender of their provider. Not all women veterans want to get care from a women's clinic, but not all women who want care from a women's clinic are able to get that care. Privacy and gender competencies of all service lines is also an issue that needs to be addressed.
Great, thank you. Thank you. I want to move on to a question about infrastructure. The independent budget requests a much higher budget request for infrastructure. Quickly, how would you prioritize VA's needs and infrastructure?
If I may, the VFW believes that, IB believes that VA has a pretty large, over $60 billion IT issue, infrastructure issue, and they're just chipping away and not chipping away as much as they can. There's a $7 billion backlog on seismic corrections, which is related to safety, making sure that these facilities are safe for veterans who are using them. That would be the priority, looking at the safety, but also the access gaps. VA can hire all 50,000 vacancies or fill them today, but they wouldn't have places to put them, and that's going to be a real big issue.
All right, my time is up. Dr. Rowe, go ahead. You're recognized for 5 minutes.
Thank you. Let it be known that I sent in my American Legion dues late, but I double the amount. How's that? I sent in twice as much I was supposed to.
We appreciate that. You're paid up for your second life then, sir.
Matter of fact, a little more than double. Interestingly, when the discussion a minute ago was on the gender issue, it took me back to my time in the military, and I served in the 2nd Infantry Division at Camp Casey, Camp Bradley, and then down in 121 EVAC in Seoul. And until I was at the 121 EVAC hospital, there was not a single, I don't remember a single female in the 2nd Infantry Division, and I think I would have. Remember that. And which is how the VA has changed. It literally was all a male organization. I mean, it was set up for men. And I never thought about it when I got here because my office as an OBGYN doctor was all set up for women. I just made the assumption that it was all set up. It's not. And you're absolutely right. I've traveled, I can't tell you how many VAs now, and some of them really have excellent facilities, gender-specific facilities. They really are good. The problem of staffing up is a problem because of our shortage of medical providers around the country. So I think VA is going in the right direction. And certainly when I heard Dr. Stone a couple of weeks ago, we had breakfast with him, that now 41% of eligible female veterans are going to a VA. That's a good number. And 48% of eligible men are going. So that's almost parity now, and that's a good thing. I give them a shout out for that. So I hear you loud and clear. I think the VA understands that and wants to get moving. I know we went through hours of discussion when we talked about the Mission Act. All of you all sat around a table. We talked and debated back and forth about the construction needs. I think one of the things we're going to need your help on is that because the VA is going to have to transform the way it's doing business. And as you mentioned, $60 billion, if we begin to make those capital improvements, it's got to be done right. And whether it's through leasing, building, I don't know what it's going to be, but when those market assessments come in, and let me tell you, this is going to be hard work that nobody if I go in and say to the local Kiwanis Club at home, hey, I'm going to talk about the air infrastructure, then they're going to run for the exits. So we're going to have to do the hard work, and it's going to be up to you guys to help us do that hard work. And that's going to be, I think, the hardest part of the Mission Act to undo, to get the VA right-sized. And it's not going to be that every congressman says, well, I got to keep this hospital of 4 people in it open. I mean, we got to have enough courage, enough courage to say, no, that's not the way it's set up. So I really do, I wish, in a way, I was going to be here another term or two to work through that, because it's not going to be easy and fun, but it is incredibly important about how our veterans, long after nobody knows who was on this dais, serves, 50 years, 30 years from now. I mean, think about 2050. That's only 30 years away. And the VA can't look in 2050 like it does today, because I can promise you health care is not going to be delivered that way. So I'm asking you right now, and I know all of you all at the table were tremendous help in writing this, and the question is, can we execute it, and do we up here, the elected officials, have enough courage to do what we need to do? And I'll let any of you answer that. It's sort of a statement, not a question.
Ranking Member Rowe, thank you so much for your commentary, and we couldn't agree more. One of the critical aspects of the Mission Act was, in fact, infrastructure review. The timing, though, I think is most important. The idea to do an infrastructure review after a market assessment was done is critical, but the idea of a market assessment was to ensure that the underlying healthcare system is stabilized.
Correct.
Now, what's happening here is we have a contract vehicle that doesn't quite align with statutory or regulatory requirements. You've got a third-party administrator that is just stepping in, trying to lean real far forward to try and meet not only the needs, but the gap in policy. And we're still waiting for the network and the subsequent referral patterns for patients, for veterans in and out of those networks, as well as a change in VA's responsibility under this new Veteran Community Care Program. We're trying to wait for all of that to stabilize to a point where we can get a better idea as far as what the workload and the demand and the need is going to be into the future. And we'll want those market assessments is to capture that. We don't want to leap too far forward and start tinkering with infrastructure, which this committee knows is very hard to deal with, decades, right?
And if I could, if I may, Dr. Rowe, and thank you very much for your leadership on that specific part of the bill. That member of Congress will insist that facility stays is because his or her constituents, the veterans who are served by that, are not happy with the replacement plan. And that is really going to be the linchpin here as to whether this works or not. And unfortunately, we are concerned that the veterans we have asked have not been asked by VA what they would like to see, what type of improvements they would like to see, because ultimately that has to be the center of it. When they went to Fayetteville and they said they did a market assessment, we asked our folks in Fayetteville, did VA ask you, what's going on? They want to, reform the infrastructure plan here. Did they ask you anything? They said no. So that's going to be an issue that needs to be addressed, and we're hopeful that, I know you share that concern, so hopefully we can.
Okay, thank you. I yield back, Mr. Chair.
Thank you, Dr. Rowe. We are now at the close of our second panel's testimony and questioning period. Again, I'd like to thank the witnesses for their appearances before and their testimony. We have heard your concerns on behalf of veterans and look forward to working closely with each of you. All members will have 5 legislative days to revise and extend their remarks and to include extraneous material. Again, thank you for appearing before us today, and this hearing is now adjourned. I'm going to get out.
Amend my comment.